All right, good morning and welcome. It's great to see so much energy in the room early in the morning. It's really exciting to look out across the room and see so many people from all over the world and all over the spectrum of dental research and public health. This is about 2 years in planning to put this event together, so really looking forward to hearing what our speakers have to share today. Our theme is Worldwide Perspectives on the Dental Care Delivery Team, which has to do, in my view, with creativity. How to address this tremendous challenge of unmet dental need around the world, and how to do that with different components of the workforce, whether they're dentists, other health professionals, or anyone interested in promoting health and preventing oral diseases. I'll keep my comments short. We have a very tight schedule today. We need to be out of this room at 12 o'clock, so we'll try to keep things moving along quickly. Only other request, you're welcome to eat in this room, but please, when you're finished, take your cups and plates with you. And in a couple of minutes, you'll be hearing from some special people who really make this event happen. One is Dr. John Greenspan. He started this event when we began with our first Global Oral Health Symposium. Without him, there would not have been a global oral health program in our School of Dentistry, instrumental in starting Global Health Sciences at UCSF, as well as the Global Oral Health Inequalities Research Network at IDR, of which many of you participate. But first, I'd like to introduce our Dean, Dr. John Featherstone. His tremendous support of this program and this symposium is what makes it possible. So, Dean Featherstone.
Thank you, Ben. Well, welcome, everybody. It's so wonderful to see so many of my friends from around the world. I haven't caught up with you all yet, but it's really wonderful to see you all. And thank you for coming. We're in for a treat this morning. And I'd like firstly to welcome you to San Francisco. And I will apologize for the rain. The last 5 years, we've had almost none. So we're making up for it now. And I would like to thank those that came from Europe, especially the UK, for bringing the rain with them, because we still can use it. They tell us that the drought is over in Northern California, but not in Southern California. All the reservoirs are full throughout California, but apparently the groundwater, the levels in Southern California are still not up there yet. So we'd like to pass some of what we're getting this week south. So if you could organize that, just talk to whoever you want to talk to get that fixed, that would be really good. I'd like to welcome you to UCSF. As you'll see, there's all sorts of construction going on. It wouldn't be UCSF if it wasn't to be under construction. 15 years ago, the Mission Bay campus down in the city didn't exist, and now we've got 2 blocks left to put buildings on. It's just an amazing campus. If you get a chance to go visit, please do. The construction that you see going on here is 2 buildings which have been essentially condemned for seismic reasons. We do have the occasional earthquake in San Francisco. Haven't had one for a long time, a big one. So those buildings are being totally retrofitted inside. That's what all the mess is, and it will go on for a time yet. So having said that, I'm very excited about today. As Ben said, it's the 7th annual Global Oral Health Symposium that we've had. We've had some very cool sessions, for sure. And it's almost 10 years since I took over as Dean of the school. We put together a strategic plan for the next 5 years. We're in our second one now. And part of that was to increase our presence in the world of global oral health. At the same time, our campus put a large emphasis on global health and brought in Jaime Sepulveda, who some of you know, who's heading up a huge global health program here at UCSF. So again, I would like to thank John Greenspan, who I persuaded fairly easily, I might state, to take on the task about 8 years ago now of Associate Dean for Global Oral Health, which was a totally new appointment here. And John took that task on and got things rolling. And now we're in our 7th annual. And I'd like to thank, at this point, Ben Shafi, who's our Director of Global Oral Health. I persuaded him. It took a little bit of persuading, but he's taken it on with great vigor and great success for putting this program together. As he said, it's been in the planning for a couple of years. I'd like to thank Ben and John Greenspan and Roger Mratz. Is Roger in the room anywhere? He's probably outside. Well, Roger and Ben and John and the planning committee and the staff, as you know, any meeting takes a team to put it on. So a round of applause for all those that put this together today. So without further ado, I hope that you're going to enjoy today's program. And one of the aspects that I'm particularly excited about, for years I've been interested in, or more than interested, in interprofessional education. And we all pay lip service to interprofessional education. And my thinking, and the thinking of a couple of other deans here on the campus, was that interprofessional education is worthless without interprofessional practice. And yet, around the world, we've been doing interprofessional practice in the ways that you're going to hear about today for a long time. And it's time that we transferred some of that to the US. At dinner last night, I was talking with a couple of people about, shall we say, oral diseases around the rest of the world. And my comment was, 100 miles from here, in the Central Valley of Northern California, we have some of the worst global oral health issues in the world, just 100 miles from here. And we could learn from what we're hearing today and maybe help persuade our policy people and our legislators to put something into practice. So with that, I'll hand over now. I'd like to thank you all for coming and hand over to John Greenspan.
Well, this is indeed an ADR Canadian Association for Dental Research Symposium as a satellite of the main meeting, our Global Oral Health Symposium. So we shouldn't be surprised, as you've heard, that our guests hail not only from across the state, from several other University of California campuses. For those who don't know, we have 10. It's really equivalent to most national university systems. And we have people here are registered from UCLA, Davis, Berkeley, Santa Cruz, as well as from several campuses of our state university system, and multiple other US and Canadian healthcare universities, institutions, companies, as well as the NIH, and you're all most welcome. But also from 16 institutions in 11 other nations. The prize, if there were one, and there isn't, for the largest international contingent goes to King's College London. Allegedly, 9 of you here, I believe, have infiltrated, listening to what we're saying, you know. Now, it could be that, as they would no doubt claim, that this is, and Deb and I are both King's alum, that this is because of King's eminence in global and public health. We think it's because they want to come and find out how to do it. Good luck. Second prizes, I think, go to Nigeria and Japan. Where are my Japanese friends? Yeah, good. So also notable among our participants are the current American Dental Association president, Gary Roberts. Gary, thank you for coming. It meant a lot to us. And if he's here, Harvey Brody. Is Harvey here? Our very own regent. The Alumni Association of the university elects one person to be a member of the Board of Regents, which is our trustees. They're the guys who really sort of say no to it. I mean, decide the main important things. And Harvey's, I think, the first dental alum, certainly the first alum from our dental school. So that's a lot to us. And Raul Garcia, is Raul here? Raul is the incoming president of the American Association for Dental Research. A number of IADR, past presidents, Steve Chalicum, David Williams, Deborah Greenspan. So it's just a joy to see all of you here. And equally distinguished is our next speaker, David Nash, who's something of an icon to those of you who are not involved in US and Canadian dental education. He's currently the William Willard Professor of Dental Education. He's a pediatric dentist and a professor of that field in the College of Dentistry at the University of Kentucky, not to be confused with the Louisville University in Kentucky, where you get into big trouble if you confuse them, particularly with certain sports events. He was dean of that college for 10 years, very distinguished dean, and of course his primary contribution to the literature in over 150 papers has been on the theme of dental education, professional ethics, and the oral health workforce. And his focus on those topics was far ahead of the field, far ahead, visionary as you'll hear, still is, and many of us have been running to keep up with him for at least the 30 years I've known David. And what he says is what needs to be said, and it isn't what everybody wants to hear, but it is what needs to be said, and you're going to enjoy that, I think. So, David, it's a joy to have you here again. It's been too long, and I'm looking forward very much to what you're going to tell us.
Thank you. Thank you. Thank you, Professor Greenspan. It's a real pleasure for me to be here, and I appreciate the invitation very much. That a few of the comments you made remind me of the quip of Jack Benny. I don't deserve that, but I have arthritis, and I don't deserve that either. So, there was a professor at Harvard University that won a Nobel Prize in thermodynamics. And as a result of that, he was invited to speak at notable universities, both nationally and internationally. But Harvard had a particular interest in him speaking to some of the great New England universities and colleges to promote Harvard in the region. And so they encouraged these colleges and universities to invite him, and to encourage him to go and to speak, they assigned him a limousine and a chauffeur. And so over a period of several years, he and the chauffeur traveled to a number of these New England universities and colleges to speak, and they got to be pretty good friends. The chauffeur would go in and listen to the Nobel laureate's presentation in the back of the room, and they'd talk about it on the way home and so forth. On this particular day, they were traveling a little north into Vermont for a presentation, and the Harvard professor, somewhat of a practical jokester, responded to a comment from the chauffeur driver when the chauffeur driver said, "You know what, Professor, I've heard you give this lecture so many times, I think I could give it myself." And the professor decided to take him up on that, and he said, "Pull over here at the next rest area." And so the chauffeur did, and they got out, and the professor said, "Here, you put on my suit, and I'm going to put on your chauffeur uniform, and we'll see if you can do it." So they did, and traveled on to the college where they were going to speak that day, and the chauffeur, alias now the professor, went to the dais to be introduced, and the professor, alias now the chauffeur, sat in the back of the lecture hall to listen to see if in fact he could do what he claimed he could do. He was introduced, and the chauffeur, alias the professor, stood up, and he gave the lecture perfectly. The professor was just awestruck that he was able to do this, but of course he had heard it many, many times. Well, at the end, the chauffeur, alias the professor, sat down, and the moderator jumped up and said, "Oh, Professor, we have about 3 minutes left. Let's take one question." And the chauffeur kept his calm. We approached the lectern, and there was this one young man down in the front waving his hand, wanting to be recognized, and the moderator recognized him, and the young man stood up and asked this long, detailed, involved question about thermodynamics. You all have been in classes with those students that ask questions because they want to demonstrate how much more they know, and that was what this was all about. So we sat down after asking the question, and The chauffeur, alias the professor, looked at him and pointed his finger. He says, "Young man, in all of my lecturing around the world, that is the most inane, stupid, and ridiculous question I have ever heard. And to prove to you how foolish it is, I'm going to let my chauffeur in the back of the room answer it for you." Well, that has relevance today because we are pleased and happy to have with us Dr. Susan Moffett, who is the Director of Dental Therapy of the University of Otago in Dunedin, and she's responsible for training dental therapists. And if you have any question at the end about dental therapists, I'm going to ask you to call on Professor Moffett to answer those questions, because I will not know. Dental therapists are members of the oral health workforce in over 50 countries of the world. Therapists have historically cared for children in publicly funded programs based in schools. Recently, a movement has developed in the United States to introduce dental therapists to our workforce in an attempt to improve access to care and reduce the disparities that we have in oral health. Today, I'm going to briefly review the global experience and the U.S. initiative, suggesting lessons that can be learned from dental therapists practicing in other countries. In doing so, I'm going to advance 3 general lessons from the international experience. I will argue that these lessons from the global experience provide the United States with the most effective and efficient strategy to improve access to care in our country and to reduce the disparities in oral health. I will conclude that the lessons from overseas offer to us a significant critique of what is happening in the dental therapist movement in the United States. The global experience with dental therapists began in New Zealand in 1921, when New Zealand established a 2-year training program for dental therapists, then referred to as school dental nurses, to staff a national school dental service. The initiative was led in part, interestingly, by the New Zealand Dental Association, prompted by the poor oral health of young men that precluded their induction into the military service to serve and participate in World War I. The New Zealand School Dental Service, now designated the Community Oral Health Service, has existed, staffed by dental therapists, has existed continuously since that time. Many countries have followed New Zealand's example, adding dental therapists to their oral health workforce, utilizing therapists in school-based programs caring for children. The scope of a therapist's practice internationally is typically or generally includes examination, diagnosis, treatment planning, preventive services, early cavity preparation, the restoration of primary and permanent teeth, stainless steel crowns, pulpotomies, and the extraction of primary teeth. In 2012, the W.K. Kellogg Foundation commissioned a review of the global literature on dental therapists. The study was conducted by 17 international investigators, and they reviewed 1,100 articles identifying 54 countries in the world where dental therapists were members of the dental workforce. The research concluded with these findings, which I am going to quote from that report. 1, dental therapist scope of practice is primarily in caring for children. 2, dental therapists practice in the public sector, typically in schools, following the original model of New Zealand. Dental therapists improve access to care, specifically for children. Dental therapists provide technically competent and safe care for children. Dental therapists in general are not licensed professionals, but rather practice as registered auxiliaries. 2 years is the typical training period for dental therapists. 7 dental therapists typically practice with the general supervision of a dentist. 8, the dental profession in countries where dental therapists practice accepts the care of dental therapists as being valuable. However, there is strong resistance on the part of dentists to therapists treating adults. 9, the public values the role of dental therapists in their workforce. And 10, dental therapists have the potential to decrease the cost of health care for children. Dental therapists have now been introduced into the American U.S. workforce. Oral Health in America, a report of the Surgeon General published in the year 2000, raised the awareness of the lack of access we have in this country to dental care and the disparities that exist among individuals. In February of 2001, Dom DiPaolo, Wendy Moradian, and I convened a small group of people in Boston to discuss the potential of introducing the dental therapist to the workforce in the United States and the ability that might have to address the inequalities in oral health care in the United States. The participants at that meeting recognized quickly that a major barrier to doing so would be restrictive state practice acts. Consequently, we contacted the Indian Health Service to determine if there could be any interest of the IHS on training and deploying dental therapists in some of the sovereign Indian territories. The Alaska Native Tribal Health Consortium, under the leadership of Ron Nagel, a commissioned officer of the IHS, responded positively to the idea. And so in the year 2000, the 6 Alaska Native students were sent to the University of Otago in Dunedin, New Zealand, to study to become dental therapists and to return to practice in the sovereign areas of Alaska. In 2007, after 3 cohorts having gone to New Zealand to learn dental therapy skills, the program was transferred to Alaska. Currently, there are 30 dental therapists practicing in Alaska, however, only on tribal lands. In 2009, Minnesota became the first state to pass legislation permitting the practice of dental therapists. 2 training programs currently exist, both offering training for dental therapists, but in combination with training for dental hygienists, with the awarding of a master's degree, programs of 6 academic years. In Minnesota, therapists may practice in the private or public sector, but also must practice with a collaborative management relationship with the dentist. 50% of their patients must be, quote, from the poor and underserved. Dental therapists are permitted to treat adults in Minnesota with restorative care basically limited to intercoronal restorations and surgical procedures that are applied to permanent teeth that are loosened significantly by advanced periodontal disease. There are 58 dental therapists practicing in Minnesota, individuals both with just dental therapist credentials and also with dental hygiene credentials. In 2014, Maine authorized the training and practice of dental therapist hygienists, as did Vermont in 2016. However, at this time, no training programs exist in either of these states. Interest in dental therapists joining the workforce exists in a number of other states, and the interest appears to be growing. Major advocacy and financial support for the Dental Therapist Initiative in the United States has been provided by the Pew and Kellogg Foundations. The American Dental Association has been adamantly opposed to the introduction of dental therapists, fighting the initiative for Alaska Natives, as well as authorizing legislation in the states. Well, what lessons, then, can we learn from the global experience? While there are exceptions, which I will mention, the general experience of the world in utilizing dental therapists in the workforce follows 3 patterns. 1, therapists focus their treatment on children, not adults. 2, therapists practice in publicly funded programs, predominantly school-based, not in private dental practices. 3, therapists are trained in programs of 2 years, not linked to dental hygienist training. Let's look at each of these 3 patterns. Globally, therapists practice on children, not adults. Of the over 50 nations identified in the report sponsored by the global study sponsored by Kellogg, fewer than 10 permit the treatment of adults by dental therapists. And in these countries, this is a relatively recent development. The care that therapists are able to provide for adults is very limited, basically the same sort of care that therapists would provide for children. However, even in those countries where some adult care is permitted, therapists predominantly treat children. Therapists treating adults has been generally opposed by the dental profession throughout the world. An early example of therapists treating adults occurred in 1972 in the Canadian North. The Canadian government established a dental therapist training program in the Yukon to care for First Nations children living in northern Canada. The curriculum was based on the New Zealand model. While the focus of care was on children, a therapist living and working in a small native village in the north with knowledge and skills that were useful in helping adults deal with dental problems, some purveyor was provided, and this was appropriate to do. The same circumstance developed in rural Alaska. While the focus of Alaska is therapists treating children, Alaska followed Canada in expanding some care to adults due to the lack of any dental services in small remote communities in Alaska. Therapist training also has existed in sub-Saharan African countries in the 1970s and 80s. In these countries, therapists have treated some adults due to the significant need for the extraction of teeth. The General Dental Council of the United Kingdom began to permit an expansion of dental therapist duties and their practice opportunities in the early 2000s. Some adult care by therapists in Australia and New Zealand is permitted. However, the scope of practice in adults in both these countries is limited and does not include restorative care past the ages of 18 to 25, depending on the particular region, nor does it permit the extraction of permanent teeth. The Dutch government has expanded the training of dental therapists by adding dental therapist skills to the training of their dental hygienists. Dental hygienists in the Netherlands are currently able to provide some restorative care with the prescriptive authority of a dentist. There are 4 issues, in my mind, that emerge of dental therapists treating adults. First, adult dental care is complex, involving a myriad of signs, symptoms, and problems requiring diagnostic expertise as well as a large repertoire of therapeutic interventions. Many adults, especially those seeking care in safety net settings, present with dentitions that have been mutilated with dental caries and or have significant periodontal disease and or the need for extraction of permanent teeth. These circumstances require restorative and surgical skills that are beyond the traditional scope of practice of dental therapists. Frequently, the argument is advanced that if dental therapists can prepare and restore a cavity on a child, they can certainly do this on an adult. I do not contest the ability of a dental therapist to provide the technical training to restore an intracoronal restoration on an adult patient. However, diagnosing, treatment planning, and providing rehabilitative care for adults is much more than just being able to prepare an intracoronal restoration, which is generally what is permitted by dental therapist legislation. Except for the small percentage of children requiring referral to a specialist, dental care for children is not nearly as complex diagnostically or technically. Care is predominantly diagnostic and preventive. Only 5% of children's care is restorative, with an additional 2% being extractions. Dental care is managed by a relatively basic regimen of amalgams and composites and stainless steel crowns. Pulpal disease is managed with pulpotomies, and extraction of primary teeth is generally accomplished in an uncomplicated way. Secondly, in my judgment, dental therapists treating adults is also inefficient. To be an efficient addition to the oral health workforce, dental therapists need to be able to practice independently with general supervision by a dentist. Practicing with direct or indirect supervision, which requires the presence of a dentist, does not really expand the workforce to underserved areas lacking dental services. There are currently 53 designated shortage areas in the United States. While a therapist in a dental office might increase the efficiency of a dentist, it does little to address the core problem of geographic access to care. As indicated, current legislation restricts the care that dental therapists are able to provide adults to intracoronal restorations and the teeth that are significantly affected with the characteristic bone loss of advanced periodontal disease. Most adults who have not had periodic dental care require more treatment than a dental therapist is able to provide. Thus, a dental therapist practicing even with general supervision in an underserved area would only be able to provide some of the treatment that the adult needed. A dentist would still be needed to address the comprehensive treatment required by most adults. In contrast, dental therapists caring for children is efficient, as therapists are able to provide all the basic care that's required by most children. Thirdly, there are safety considerations in treating adults. Dentists receive an extensive education in identifying, assessing, and managing the general health and well-being of patients. Comprehensive courses in the biomedical sciences, as well as in oral diagnosis, oral medicine, oral pathology, prepare dentists to address the health constraints of the increasing number of elderly and biologically and pharmacologically compromised adults, and adults with silent or undiagnosed disease. Dental therapists receive only limited such training and thus are not really equipped to evaluate and manage the care of health-compromised adults. I do not have any reservations regarding the ability of dental therapists to safely treat adults under the direct or indirect supervision of dentists. However, I do question their ability to treat adults when practicing under general supervision, absent some sort of an examination, evaluation of the patient by a dentist. As I have indicated, practicing with a dentist on site does little to improve access to care. In fact, it really places the dental therapist in the role of simply another member of the dentist team in his office with expanded functions. Other than the small minority of children identified as having special health care needs, children are healthy. Children can be safely treated by dental therapists with general supervision, as over 90 years of international experience has documented. The research frequently cited in the support of the clinical quality, safety, and effectiveness of treatment by dental therapists, by proponents of dental therapy, is based on therapists treating children, not adults. I am not aware of any scientific studies on the clinical care of dental therapists specifically treating adults. Lastly, treating adults rather than focusing on children raises ethical issues. The opportunity to realize one's potential in life is markedly affected by one's childhood. All children are vulnerable, made so by the time-critical nature of their development and the implications for all aspects of their later life. What happens in the life of a child is determinative of whether that child will have fair opportunity to fulfill his or her unique potentials. Theories of justice advanced by both philosophers and healthcare ethicists support children receiving priority consideration in healthcare. When resources are not adequate to care for all, children are to be prioritized. Indeed, this is the current practice in the United States regarding oral health care. States are mandated to include children in Medicaid, but not adults. The majority of states only provide emergency or very limited treatment for adults under Medicaid, and some provide none. Those advocating that dental therapists treat adults to help address the access to care issue for the, quote, poor and underserved are presented with a real challenge. From where will the resources come to pay for adult care? The worthiness of a society can be evaluated in terms of its concern and its care for its children. It is not surprising that the moral compass of societies throughout the world has prioritized children in focusing their public resources, both financial and workforce, on dental care for children provided by dental therapists. President John Kennedy expressed it well when he said, quote, "Children may be the victims of fate. They must never be the victims of neglect." The second global lesson is that therapists practice in the public sector, internationally, not in the private. While dental therapists practice in the public sector caring for children in over 50 countries of the world, the public school-based programs in New Zealand, Malaysia, Singapore, Hong Kong, and formerly Saskatchewan, Canada, are noteworthy in their achievements. In New Zealand, 98% of school-age children and 60% of preschool children are provided preventive and rehabilitative care annually by dental therapists. A report of the oral health of New Zealand school children documented that 52% had never experienced dental decay, and of those who had experienced dental decay, 80% had been treated. The average cost of care in the New Zealand dental service in 2011 was $99 per year. Malaysia was the first country to follow New Zealand's lead in establishing a school-based program staffed by dental therapists. The program resulted in a sharp decline in tooth decay and a corresponding increase in treated teeth. One study indicated that 97% of elementary school children and 91% of secondary school children had been rendered, quote, orally fit. When Singapore's school dental service began in 1946, it was determined that 98% of the children required dental treatment. A 2009 study found that 89 to 96% of those children had been rendered dentally fit. The result was attributed to the establishment of a school dental service staffed by dental therapists. Hong Kong established a school-based dental service with therapists in 1981. By 2011, the participation rate of primary school children in Hong Kong in this service was 95%. 62% of children aged 12 had never experienced a cavity. The average number of decayed teeth was less than 1, and essentially all the decayed teeth had been treated. The estimated annual cost in the Hong Kong School of Dental Care Service in 2012 was $78 US. A particular note as a lesson for us in the United States is a program that exists in Saskatchewan, Canada. It's the only program to ever have existed in North America providing dental care for children in a school-based program, staffed by dental therapists. A 2-year training program based on the New Zealand model again was established at the Wascana Institute of Applied Arts and Sciences in 1972, and the school program was implemented throughout the province's elementary schools in 1974. After only 6 years, 90% of the province's children had all of their treatment needs completed during the school year. When the program closed in 1988 as a result of the pressure from the province's dentist and the election of a conservative government, the decay prevalence for 6-year-old children had dropped from 6 teeth to 1, with essentially all of the decayed teeth having been treated. A study comparing the Children's Dental Program of Saskatchewan and Newfoundland, both publicly funded programs, found that Newfoundland's program only had a participation rate of 45%. Newfoundland's poor participation rate was attributed to having treatment provided in private dental offices by dentists rather than in school-based programs staffed by dental therapists. Of interest to me is that the 45% participation rate in Newfoundland is comparable to the 50% of children who have had a dental visit in the United States within the last year. This suggests the major barrier that exists in getting children to private dental offices for care and accessing care. School-based health care eliminates this barrier. The annual cost of care for a child when the Saskatchewan program closed was estimated in 2010 dollars to be $176 US per year. In the U.S., 51% of our elementary school children have experienced dental caries. 67% of our teenagers have a history of dental caries. Among our children who have had dental caries, 25% of the lesions remain untreated. The average cost for elementary school children in the United States in 2015 was double Saskatchewan at $416 per child and 4 times the cost of New Zealand and Hong Kong. Many of the adverse determinants affecting health generally and oral health specifically are overcome by housing health care for children in schools. Schools are where children are most accessible. School-based health centers reduce health inequalities and improve access to care. As one academic pediatrician has expressed it, quote, "School-based health centers are the best model for health care in the country for at-risk populations. They increase access to health care, eliminate barriers, and improve health outcomes for essentially every child enrolled," end quote. This view was also expressed 40 years ago by Dr. James Dunning, the dean of the Harvard Dental School and noted public health dentist, when Dr. Dunning said, quote, "Any large-scale incremental plan for young children, if it is to succeed, must be brought to them in their schools. This implies the unsuitability of private dental offices alone for a national program," end quote. Oral health is a social good. It's a public good. As such, oral health for children is comparable, in my mind, to public education for children. It's a good that I strongly believe must be addressed in the public sector, no different than education. The oral health care for over 1/2 of America's children is paid for with public tax dollars through Medicaid and the Children's Health Insurance Program. However, care is left to the private practice, fee-for-service marketplace of care, resulting in significant barriers to children receiving oral health care and creating immoral inequities. We pay for the dental care of a significant number of our nation's children with public dollars, and yet provide the care in the expensive private sector. In countries throughout the world that employ dental therapists caring for children in public delivery systems, the strategy is exactly the opposite, as are the results. We pay more, and we end up having poor oral health overall. A final lesson is that globally, therapists are trained in curricula of 2 academic years, training not linked to that of dental hygienists. The introduction of dental therapists in Alaska prompted the American Dental Hygienists Association to promote the role a dental hygienist could have and contribute to the expansion of dental hygiene education to include dental therapist skills. The ADHA promotes the concept of a master's level advanced dental hygiene practitioner, a dental hygienist with therapist skills. The only two training programs that exist outside of Alaska are both in Minnesota, and both offer training only to dental hygienists who want to develop dental therapist skills. And they both are graduate-level master's degree programs requiring 6 years. The ADHA reports that 9 other states are currently considering adding dental therapist skills, and 8 of those would require that the person also be a dental hygienist. Australia and New Zealand have recently become exceptions to the international tradition of dental therapists in that they are now combining dental hygiene and dental therapist training in a 3 academic year program, certainly to be contrasted significantly with the 6 academic year program that's being advocated by the American Dental Hygienists Association. The integration of therapist and hygienist education in Alaska and New Zealand, as well as these 3 states, is interestingly associated with legislation that permits dental therapists to practice in private dental offices and to treat adults. Clearly, integrating the function of a therapist and a hygienist expands the ability of a dually trained person to function more effectively in a private dental office and to treat adults. However, internationally, dental therapists have treated children in public programs. In this prevailing historic context, dental hygiene credentials were not necessary because skills specific to a dental hygienist are not required to treat a child. While training dental hygienists as therapists to treat adults has benefits for dentists and others in the private sector, it does result in increased educational time and cost. The dental therapist movement in the United States is being transformed into a movement to expand the scope of practice of dental hygienists rather than just actually adding dental therapists to the workforce. This also detracts from hygienists focusing on their traditional role and value of treating periodontal disease in adults. The treatment of adults by therapists in a private practice setting also has the further effect of diminishing the historic moral prioritization of dental therapists caring for children. Combining the training of therapists with that of hygienists would not be necessary were therapists to focus their care on children, as is the international tradition. In conclusion, from a public health population perspective, the only programs utilizing dental therapists with evidence-based success have been those programs one in which therapists treat children, 2 in which they practice in the public sector, and 3 in which they are distinctive members of the oral health workforce with credentials not including those of a dental hygienist. Lessons from the global experience with dental therapists suggest a significant critique, I believe, of the current trends that are existing in the dental therapist movement in the United States. I challenge those trends. From the international experience, the lesson for the United States is that we should provide dental care for our children in public school-based programs staffed by dental therapists. Such a delivery system will result in the most effective and the most efficient utilization of our nation's resources in improving access to care and in reducing the immoral inequities that exist in the oral health of our nation's children. Thank you.
Dr. Nash, would you take a few questions if we have them?
We have a question on this side.
Professor Moffat, are you ready?
I think we have a question here.
Yes, please.
Hello? Is this working? No. It says it's on. Anyway, I'll just speak louder.
Please.
So Sheila Bray, UCSF. Right. So my concern is not for who does what, what role. Different roles people have, whether it's a dental therapist or a dentist. My concern is that we continue to use a surgical approach to dental caries rather than intervention and prevention and management. And that's my biggest concern of the waste of money and resources into approaching the disease that way. I wonder if you have any comments on that.
Oh, I totally agree with you. The work on silver diamine fluoride, for example, is beginning to transform what we're doing in our pediatric dentistry residence programs and treating children. However, many of the tools that we need to use to develop or to implement the preventive regimens have to be implemented by someone with some professional skills. Our next speaker is going to suggest to us, I think, how limited education one needs to implement some of those. But nonetheless, we are educating. We have a fee-for-service delivery system in the United States that leads people to the more services they provide, the more expensive it becomes. And that's true of preventive services as well. For example, this next week, my pediatric dentistry graduate students are reading an article where the systematic reviews suggest that if a child is at low risk for dental caries, lives in a fluoridated area, and brushes their teeth with a fluoride dentifrice, they do not need the semi-annual application of a topical fluoride. There is no justification for, in my judgment, and I think the evidence supports me, for dental prophylaxis for children, rubber cup prophylaxis. And yet, my colleagues teach that. General dentists around the United States use that. Pediatric dentists, every 6 months you come in for a prophy, and there's no therapeutic value to it. So we need to come up with preventive therapies that can be implemented across the community, and I want to argue that I think those can best be provided by people with dental therapist skills, working in schools, working with not only the elementary school children, but actually the preschool children as well.
Thank you.
Dr. Nair, intertwine school-based programs with dental therapists. It seems like what should come first is the acceptance of school-based dental prevention programs in schools, which we get much resistance for, and then later the therapeutic part. So you intertwine the two. In most countries, the therapists are involved with school-based systems. In the United States, we don't have the school-based access or the dental therapists. What's your comment on that issue?
I'd like to comment that this is a classmate of mine from the University of Kentucky many years ago. And that's the most foolish question I've ever heard, Stephen. I'm going to let Dr. Moffitt answer it for me.
Well, the foolish question is who's going to win the basketball game Friday between Kentucky and UCLA?
Certainly, the University of Kentucky alum speaks wisely. Of course, we need preventive programs in our schools to the extent we can, but and maybe that is a first step. But I hope that I've been able to demonstrate with a few examples of here with what can be done. We have an article coming out in Journal of Public Health Dentistry on this case study, the Saskatchewan program. Many people never heard of it. But they were able in 1 year of planning and 2 years to implement school-based programs throughout the entire province of Saskatchewan and deal with the issue of school-based preventive activities, but also taking care of the kids. Prevention is wonderful. Prevention works, but prevention doesn't always work. And so I think it's incumbent upon us when prevention doesn't work that we provide avenues to our children to treat the dental caries that we've not been successful in preventing.
David,
Professor.
John mentioned interprofessional education and practice, and I think the panel will discuss this, but can you give us your views on the role, several levels really, it's a progression, on the role of pediatricians, pediatric nurse practitioners, education of teachers, parents, the public, politicians, in the roles of sugar and of personal oral care in what is the really upstream challenge of oral disease, particularly in children?
Well, as I think everyone in the room knows, early childhood caries is a significant problem in the United States, but also globally, and that suggests you have to reach children with preventive strategies early on and their parents. Some people have been critical of me saying dental therapists should focus their care on children and say, well, the adults are involved in the care of children, and adult mothers transmit strep butans to their kids, so maybe we need to also include adults. Well, that in an ideal world, that would be great. We only have limited resources, so where do we begin? I think the issue of early childhood caries raises the question of interprofessional work with pediatricians. The average pediatrician and general practitioner who treats children sees your child 13 times for well-child visits and immunizations by age 3. My American Academy of Pediatric Dentists has advocated a one-year visit by the dentist. We can't get children to come to the dentist when they're 5- and 6-year-olds, let alone get parents to bring their infants to a pediatric dentist, but they do take them to the pediatrician. And I think that there is the American Academy of Pediatrics as well as the American Academy of General Practice Medicine both have excellent continuing education programs online about oral health. And we just need to work more with those groups to the extent we can. I created quite a bit of controversy in an early article I wrote on dental therapists by suggesting that there's nothing, and looked at the state practice acts, there is nothing that would preclude in most every state in the United States a pediatrician from hiring a dental therapist and putting him in their office. Now think about what kind of transformation that would be. If you had a person there that was focused on the care of children and working with the pediatrician, not dissimilar to the physician assistant or the nurse practitioner the pediatrician may have. I think there's a lot of merit in that, and we do have to involve more people in this effort. We, as a dental profession, cannot do it by ourselves.
We'll take one more question.
Here's a big one for you, David. This is John Featherstone. Just a very quick snippet here. As many of you in the audience know, I grew up in New Zealand, and I was one of the casualties of the dental nurses program, because at that point, prevention consisted of drilling out the occlusal surfaces and filling them up with amalgams, because that was thought to prevent latter disease. However, the point of the story is that roll on to the late 70s, when by regulation the director of the program in New Zealand could say, you will no longer do that stuff, you will treat in a different preventive way. And that's when the dramatic reduction in dental decay in New Zealand started. So having said that, there was a policy change. So one of the huge things, and Saskatchewan is an example, unless the public policy and the politicians and those who direct resources can be persuaded to make the change, everything that you've done, that I've done, half a dozen people in this room have done, is totally wasted. And then you said the program was stopped in Saskatchewan because of a change in government. How do we overcome that problem?
Leave it to a dean to ask an unanswerable question. I was commenting, we were standing up here talking before the session began. The problem of oral health care policy for us in dentistry is no different than the general health policy that exists in the United States. We pay more for our health care than any other country in the world. We have poorer access to care than any other country in the world. We have poor oral health or general health outcomes than any other country in the world. And we're probably not going to be successful, as Dean says, we're not going to be successful. It's a political issue. Just with all consideration to our guest, the ADA president, the ADA has fought vociferously about introducing dental therapists, and the ADA has a lot of political clout. And so when our own profession is not advocating for the kind of access that we need for children, then we certainly are not going to have any success in getting the Congress and our presidents. I will tell you, though, as my last comment, that Bernie Sanders, about 3 years ago, held a hearing in Congress on dental therapists and the role that dental therapists could play in improving access to care for children. So there are people out there. Now we have the Kellogg Foundation, the Pew Foundation, both very influential, except I think that my judgment, they've gone a little bit off track in some of the emphasis that they have, but they certainly are having an impact on people thinking more about the role of access to care for children and adults. Thank you all very much.
So to introduce our next speaker, I'd like to welcome to the microphone a tremendous friend of the UCSF School of Dentistry and a great advocate for children's oral health and children's nutrition and well-being, Dr. Karen Sokol-Gutierrez of the University of California, Berkeley.
Good morning. I'm really honored to have the chance to introduce Laura Sparrow. Laura is the founder and executive director of Javaya Foundation, a non-governmental, nonprofit organization that works in Nepal to recruit and train community health workers, dental technicians, to provide prevention and treatment for the rural population there. And they're currently serving over 60,000 people, and they hope to expand to serve all of Nepal. I'm really lucky to have been introduced to Laura a year ago by Ben, and I've gotten to know Laura very well, first by phone and Skype, and then I had the chance to bring a team to Nepal in December for 2 weeks to work with Laura there, and I've been tremendously impressed by the work that she does there. Laura went to college at Williams College, and she majored in anthropology and neuroscience, which you might think would be an unusual background for getting into oral health, but what I've seen in the field is that Laura's background in anthropology has completely shaped her approach to the work that she does. And I have to say that Laura really has an extraordinary finger on the pulse of the Nepali culture, their needs, their capacity, and their ability to embrace this improvement of oral health. I want to engage in a little self-criticism. Those of us in academics, the ivory tower, and those of us with gray hair sometimes look at people from the outside saying, where are her advanced degrees? Oh, she's going to present something to us without data and graphs and tables and charts. And can we believe that this is the reality, this is true? But I want to assure you that Laura really does understand what's happening in Nepal. She has lived there and worked there for 14 years. And when I got to see Laura working in the field, I could see that she really understands the people. So I want to ask you to do this. When Laura comes up, I want you to not see her as this young American woman, but I want you to close your eyes for a second. I want Laura to actually introduce herself in Nepalese. And yeah, I know this is a surprise to Laura, but to introduce herself in Nepalese, close your eyes, and then you can open your eyes and imagine that what Laura has to say is from the Nepali people speaking to us, okay? And listen to her, understanding that she really does have her finger on the pulse of what's happening there, and she's telling us something that's very, very important for us in the ivory tower to hear. Thank you.
Okay. So I guess we can start with the surprise eye-closing exercise. सबैलाई नमस्कार, मेरो नाम लौरा हो. म 14 वर्ष भयो नेपालमा काम गरिरहेको नेपालीहरूसँग मिलाएर, अनि हामीले यो जीवाया फाउन्डेसन सुरु गरेको मुख स्वास्थ्यको बारेमा 14 वर्ष त्यति 10 वर्ष जति भयो त्यो काम गर्दा हामीहरूले धेरै सिकेको छौं. आज मलाई यहीँ बोलाएको धेरै धन्यवाद. Thank you so much, Karen. That was a very lovely introduction. And thank you to UCSF and to Dr. Chaffee for having me here today. And also to Dr. Nash for kind of warming up the crowd. We're about to take it up to the next level here. We're going to Nepal. We're in the middle of nowhere. Nobody has any training in anything. So I hope you guys are ready. As Dr. Karen said, my background is in anthropology. So I'm going to approach this from more of a sociologic perspective, which is kind of a different point of view, and I really look forward to a rollicking discussion about this during the panel. So before I get to dentistry, I'm going to briefly take us back a little and just kind of say, a bit about how we got started. Back in 2002, I had just graduated from college at Williams College, and I went to Nepal to volunteer as a teacher in a village called Keynote, which, as you can see, is an extremely beautiful place. And I stayed with a local family here where I spent a lot of time just participating in everyday life. You know, carrying bales of hay on my head, making things out of mud, doing field work with the neighbors, carrying water in baskets. I gradually picked up the language and fairly quickly became pretty proficient in speaking Nepali language. And before long, people were just coming to this house where I was staying with a local family with all kinds of questions and problems about education. Somebody asked me about how to get, kids adopted, work, travel, just all kinds of things, but particularly with requests for medicine. So I just kind of became a listener of extremely random problems, and one of the most common requests that I got was for help with dental pain. So people would come to me in the middle of those terrible pain episodes with terrible toothaches, just asking for help. To which, of course, at the time my answer was, I'm 22, I'm a liberal arts major, I can write a story about that. That's about all I've got. But I really started to wonder, what's going on here? So I started looking into it, really just so that I would know what to tell people when they came and they asked me this question. And as it turns out, what I learned is that dental medicine is entirely excluded from the public healthcare system in rural areas of Nepal. And the result is that oral disease is one of the most prevalent health problems in the country. This sort of condition that you see here is not out of place in the community where I was living. So I started problem solving with the people who I worked with, which was local teachers. And our efforts evolved over time. There was a lot of trial and error, and became Javaya Oral Health Care, which even now, 14 years later, is still the only sustainable oral health care project in Nepal, which goes to show you what a low priority it is in the development sector, in just kind of the whole healthcare sector. I think certainly in Nepal, but I would say internationally in general. So what I want to emphasize here before I launch into describing what our program model is as Dr. Karen warmed everybody up for here, when we started, we had absolutely no idea what we were doing. It was me and teachers in a village in Nepal. And this is a theme I'm going to come back to, because I think that not knowing created a kind of open-mindedness that has been very important in the development of this project. So one reason that not knowing had value is that without realizing it, we were starting for what I would later understand is a human rights mindset. Can I get a show of hands in the room? How many people are familiar with this term, rights-based healthcare, if this means something to people? Okay, so I'd say a good half the room at least. So this comes from the Universal Declaration of Human Rights, developed by the United Nations. And I'm not going to be using a lot of text in my slides today, but these are really important words that deserve some inspection. So let's take a look at them. The Universal Declaration of Human Rights describes the right of everyone to the enjoyment of the highest attainable standard of physical and mental health, the creation of conditions which would assure to all medical service and medical attention in the event of sickness. Now, what the Universal Declaration of Human Rights does not say is, develop medicine, then try to reach as many people as possible. A human rights-based concept of medicine is reach everyone and develop the highest attainable standard of care. So this treats medical care as an entitlement. And it's not the entitlement to get treated, but to the conditions that allow you to get the care that you need when you need it. So those conditions should have characteristics that are spelled out in various international human rights instruments, but it basically comes down to it should be good, it should be there when it's needed, it should be accessible to everyone. And I should mention that while I'm going to be talking about Nepal, these human rights concepts are very applicable in a domestic context. They very much apply to the talk that Dr. Nash just gave as well. So if we put this in the context of Nepal, you've got this situation where people are looking for dental medicine in a village called Keynote. So what's the environment around them? Nepal has a very centralized public health system with national, regional, and local levels. And each village has what's called a health post, which is staffed by one primary health care worker, and we're going to come back to that person in a minute. Actually, this whole system is staffed by tenured government employees and contains a grand total of 30 spaces for dentists in a country of 30 million people, none of which are at that local health post level. So health posts, which are the primary source of access for about 80% of the country, so that's over 20 million people, offer no dentistry at all. And over time, this is what Javaya Foundation has taken on, is establishing rural dental clinics in health posts in collaboration with the government. So up till now, we've established 8 rural dental clinics that serve an area of about 50,000 people. We have 2 more that we started. We ran for a period of time, and when we tried to move into the sustainability phase, they didn't succeed. That's part of what this involves. You learn a lot from that as well. And we're now trying to get this model adopted into the entire national healthcare system. So our model uses some unconventional ideas. We started with a little bit unconventional, now we're going to go way unconventional. And that's really what I'm going to focus on today, because I think we need to question what makes us attached to which conventions if they potentially exclude millions of people from healthcare. So I'm going to ask you all to walk through an exercise with me today. You've got this room that you see here in the health post in the village of Sindre. This is after we cleaned it. And the nearest hospital is at least a day's travel away. The roads get almost completely washed out in the summer. What is the highest attainable level of oral health care that can be achieved in this setting? And for today, for my talk, we're going to take a rights-based approach and say, we have to do it. People are entitled to the best possible thing that we can come up with here. So I'm going to tell you how we've approached it, and then we'll, talk about what your responses are to that. So our rural dentistry design is entirely community-based, but before we even think about a clinic, we work through the government at each of those different levels that you saw to coordinate support for dental care in a specific village health post. And from there, we work with the local government to select a team of 3 people. That includes a technician, a clinic assistant, and a team leader who acts as kind of a community liaison. And these 3 people become 2-year employees of our foundation, but they are all local to that community. And from there, the first step is to set up the clinic. So how do we set up a clinic in that space I just showed you? First of all, technicians come to us with what's called a community medical assistant degree. They have to have that degree in order to qualify for our program to become dental technicians. It's an 18-month course of study that's the same degree that's held by those primary health post workers. So in other words, it's equivalent to the credentials of the highest level provider that already exists in that setting. And then we partner with a Nepalese organization, which is called Health Development Society Nepal, and they provide training in diagnostics, ART, and extraction. And HDSN itself, just to give you an idea, was derived from the United Mission to Nepal's 5-year oral health program, which was run by Dr. Robert Yee, if anyone here is familiar with his very extensive work in that region of the world. So the basic foundation of the technician training doesn't happen within our agency. It's done through a partnership. And that training takes about 2 to 3 weeks. Now, interestingly, the government of Nepal and various local hospitals also contract with the same agency, but most trainees go home and will likely not get any follow-up. So they take their tools, they may choose to practice, but there really aren't any regulations or oversight in place for those types of providers. And what we've learned over time is that the standard can be raised well beyond that. 2 weeks of training, 2 to 3 weeks of training, it's a solid foundation, but it's not enough. So we do a lot of other things. We pair the technician with a mentor who's an experienced technician. We conduct regular supervision. We provide follow-up training. We hold an annual medical audit by a dentist. In terms of materials and supplies, all of our clinics have dental chairs. And we've actually, at this point, developed our own infection control protocol that's much stricter than the basic requirements. And then most recently, we've partnered with Dr. Bethy Turton, Dr. Carrie DeCepolo at the University of Connecticut, and Dr. Karen Sokol, who you just heard, to add silver diamine fluoride and fluoride varnish to these clinics. So through our program, we've developed and added a lot of things that go far beyond the standard accepted training and operations for these same services in Nepal. So all told, our technicians get at least 2 years of supervision and mentoring before the clinic is finally handed over to the community. That said, we are working in very traditional settings, in health posts. Many of our clinics don't have electricity, none have running water. You can see that this clinic in Salyan has a tin roof, and it's in a traditional plastered building. We do have a requirement that the clinic room, which is provided by the community and the health post, has to have secure doors and windows, and it has to meet cleanliness standards. And we try very hard to get a dedicated room, but that's not always possible. So this picture you see here, this is an example of a clinic where they have to share that space with a number of other functions that are occurring in the same room throughout the week. So at the end of the day, the question is how to innovate and push that standard higher within the constraints of the environment that we're given, to provide the best care that we can achieve for patients who come there. So that's the clinic. But setting up the clinic is the easiest part of what we do. It takes a few months and then it's there. But we all know here that the clinic is only going to be useful if the community is engaged with it. And we're talking about places where people think that maybe the random foreigner college student person is a good option to approach with ideas about dental care. So, and that's actually a really interesting question. That's a topic for another lecture, but why is the random foreigner with no qualifications at all even worth approaching with this issue? That's a topic to mull over for another day, but an important one. In any case, in most rural communities, oral disease is an accepted fact of life. There's an assumption that you lose your teeth as you get older. People just kind of power through those pain episodes the way that they did when I was first living in Caskie-Cote. So we really have a lot of work to do to think about how to change those expectations so that people can take a role in their own health and make use of these resources as we develop them. So I'd like everybody to take a moment and imagine, when you think of outreach programs in places like rural Nepal, what do you picture? I think we'd probably all agree that oral health outreach in this environment is commonly delivered through short-term missions or health camps. The typical outreach model involves distribution of brushes and toothpaste, probably some education about hygiene practices, most likely comes along with a burst of treatment, which very often would be provided by foreign outsiders, maybe some local outsiders, definitely not people who are from the community itself. So on one hand, if our goal, going back to that initial idea of human rights, is to create conditions that give people agency over their health care when they need it, there are obviously some problems with the camp and mission models, despite whatever benefits they provide. But let's set that aside for a moment and just look at this idea of product distribution and education about hygiene practices. This is a baseline survey that we did back in 2015, and the results are interesting. We had a pretty large sample set here of over 3,000 participants spread across 3 non-adjacent areas in Nepal. 95% of people said that they brush their teeth with toothpaste and that they can buy the products they need. Less than 1% of people said there was nowhere they could buy toothpaste. Now, I've lived in rural Nepal over the course of nearly 15 years, and I can tell you that these numbers do not accurately represent behavior. But they do show us that people know the right answers. And it shows us that products are most likely available, probably more available than we were assuming. And clearly telling people what they already know and giving them stuff they can already get may not be the best intervention that we can come up with. On the other hand, here's another set of answers from the same survey. So there's a very low knowledge of fluoride, and distinguishing, therefore, between fluoridated and non-fluoridated toothpaste. Also, a very high number of people are illiterate in this population. The second question is really interesting. 50% of people told us that they could find dental care at the local health post, which we know does not have dental care. But what it does do is it distributes painkillers and antibiotics. And so this kind of points to the suggestion, something that we've experienced just through the course of our work, which is that oral health is thought of more in pain terms than in disease terms. And then, of course, there's another 20% of people who said there is none. So you kind of put those two things together, and we're talking about 70% of people who are not giving us an answer that indicates that they have any kind of real access to dental medicine. This next question, fear of non-associated risks, such as blindness and deafness. This is a problem we run into all the time. I actually wonder if these real percentages are higher. We did this survey. It was a household survey, so we interviewed whoever was home. But this question of fear of blindness, fear of deafness, fear of body weakness, there's this grave, worry that if you have any dental work done, you shouldn't do too much because it can sort of like weaken your whole body. And then just kind of not so much a culture of prevention. So we only had 37% of people who said that they would get a dental checkup annually. Again, I'm going to kind of fall back on the non-scientific credential of having lived in this community for 14 years. That 37.4% is about 37% too high. There is no culture of preventative screening, none. And you have 70% of people who cannot identify a place where that, would even occur. So what this data starts to suggest, there's obviously a lot more that we could look into this and come up sort of specify further. But what this data starts to suggest is that while there is some key misinformation, overall, oral disease is more of a lack of prioritization. There's no culture of oral hygiene or of dental medicine. It's experienced as a pain problem and a cosmetic issue. There's inadequate access to treatment. These are the ways that we want to start framing the problem as we're working at the community level. So when we do our community outreach and education, it's focused on those issues. And I should say, first off, community outreach is conducted by that same 3-person local team, the technician, the clinic assistant, and the team leader. So by the people that are running the local clinic in that village, which allows them to be very nuanced and consistent with messaging over time because they're integrated into that community. And when they provide free screening during their outreach and they create referrals to their own local clinic, they're the people who are then in the clinic when people come for services. So we're really emphasizing that personal agency that's so important to the rights-based framework, but we're also really ultimately, the purpose of this outreach is to create a bridge between the community and the local dental clinic, and that's something where you need the infrastructure in place, and then you need this sort of iterative process where you go back and forth between those, where you start to reorganize some of the relationships that are involved and change some of the patterns of the ways that people are doing things and thinking about some things. So really, a lot of our outreach is, I think of it more as generating different and more accurate conversations about oral disease. And those conversations are now happening between different members of the community that have roles in actually addressing the health problem itself. And this, of course, all doubles as intensive, ongoing, supervised training for the clinic team as well over the course of these 2 years. So a couple other things they do. The team helps each school select one teacher who is assigned the fancy title of oral health coordinator and helps them start a daily school brushing program. This happens at every primary school in the village. So all children up through grade 5 brush their teeth in school, and that ties in nicely with the talk that we just heard. In addition, that starts to provide a framework and an infrastructure for integrating oral health care into schools in other ways. So another thing the team does, this 3-person team, is they come to schools to do what we call seminars. And we don't call them camps because the purpose is really kind of different than a camp, even though from the outside it might look a little bit similar. The teams are working with that oral health coordinator to do a whole day of oral health activities and screening for students and parents, and building the long-term capacity of schools to do the oral health education and the health coordination for students and for their families. And the last piece is vendor outreach. So we have specific programs where we work with shopkeepers in the village to make sure that dental hygiene products are locally available, where they're easy to get. What you saw in the survey data is relatively accurate for the most part. There are products available, but one of the things that we do is make sure that vendors can distinguish between fluoridated and unfluoridated toothpaste. So we try to make sure that that's the toothpaste that's available, and then we have programs that specifically link up schools to vendors. So we kind of push that pairing so that schools will get in the habit of providing those supplies for their school brushing programs. And we're just starting now, actually, after our collaboration this winter with Dr. Karen and with Dr. Madhurima, we're starting to bring in a nutritional component where, again, we're working with shopkeepers and with school teachers on what children eat, at least during the school day, where we have a little bit of control over that. But I think you see the idea that here that we're trying to think about the whole environment of oral health care. So this is kind of a summary graphic of the model. And after doing this for 2 years, we essentially have a graduation where each component of the project is handed over and absorbed into local institutions. So schools take over those brushing programs. The cost of the brushing program is about $1 per year per student, which is an amount that can be financed by students or by the school. It's about 10 cents a month. And a lot of kids would bring that amount per day to buy like snacks or cookies at school. So schools take over brushing programs and absorb that educational component. Vendors should really be able to continue selling the products that are needed. The community has gained this kind of multi-system education about some of these different issues. And the most challenging part, as I will discuss in a minute, is turning over the clinic itself to government funding. This is our biggest challenge. But by the time that technicians graduate, they've usually conducted, give or take, roughly 2,000 procedures, both in the community and in the health post. And I would dare to say, and I welcome anybody to design a well-structured research project on this, that our technicians are actually more versed in the rural context, more comfortable there, more knowledgeable about the conditions there and the resources that they have to work with than even Nepali dentists coming in from hospitals by the time that they are through this whole process. And I would add to that I've seen this over and over, the way that technicians grow into this role. They professionalize it. They take pride in the status that it gives them in their communities. And I want to pause there on that because that is an extremely valuable opportunity to nurture that sense of ownership, which can be something that is so difficult to find and make a connection with when trying to create these kinds of systems. So I'm quickly going to show two about 30-second videos here. This is an example of an oral health coordinator running a school brushing program.
3, 4, 5 गऱ्यौ उ दीक्षा गासे दीक्षाले समाउनन ठ्याक्कै यो बीचमा राखेर समाउनु ठ्याक्क हुनु जान्छ उ यता अगाडि आऊ यसरी यसरी तलमाथि के मनमाने गर्नु हात चाहिँ तलमाथि अनि यताको सानी अर्कोतिर यतिकै देख्न पाउनु छैन छैन नि गर्नु भयो 5 अनि यता फेसिलिटी मानेको भएन 5 गोल गोल अन्डा है अब 1 2 3 4 5 गर्नु गोल गोल अन्डा लिएर जस्तै है अनि त्यसपछि अहिले नथुक
All right. That's kind of an early one. As they get going, they sort of stand in a line and they all go, and it's a little more military style, but I think these are more fun. And this is about a 30-second video of one of our clinics in Bharat Pokri, in the village of Bharat Pokri. This is a nicer environment. Not all the health posts look like this. The technician's name is KP, and the assistant is Pavitra.
Bharat Pokri.
त्यसपछि यताकोलाई चाहिँ 8 हप्ता आउनु म निकालिदिन्छु अहिले त त्यही एउटा मात्रै खायो अनि मिलाएर देखिन्छु म दबाई मिलाएर देखिन्छु त्यसपछि दबाई खाने.
This is the Bharat Pokri health post.
Okay. This was going to be a surprise picture of a yak, just because I've been talking about Nepal for a long time, and people like really want a yak, and they want Mount Everest, and I found a picture of both at the same time. I've never, there are no yaks in the part of Nepal I live in, but there's one here. Just because I know that, like, if it says Nepal on the flyer, and then everyone's going to leave and be like, there was no yak. It's happened to me before, so okay. So now we're kind of at this turning point where we're really looking to see this model incorporated into the national healthcare system in Nepal. And last summer, we launched into government advocacy. And we've had some discussion today already come up about policy. This is really important, because otherwise you're just swimming upstream against every possible cultural, political, financial resistance. This is how you start getting power structures more kind of going in the same direction. So this is me actually talking with district-level officials. You saw that sort of three-tiered graphic at the beginning. This is at the regional level in Nepal. And our pitch here, basically, is that if Nepal's government would agree to fund established dental clinics that have gone through this whole process that I just described, that would incentivize the global aid community, which currently spends nearly $1 billion a year in Nepal, to follow the blueprint that we've started to lay out here, including to collect more evidence on it. But also including the protocols, the best practices, the social components that we've developed here, and to get more ideas involved. Right now, my organization is really the only one that's doing this in this comprehensive way in Nepal. And so we don't want to be in that vacuum. We want to create reasons for other people to be innovating in this space. But it's really the government that needs to create that incentive by putting standards in place and saying, we will allocate funding through the health ministry if these standards can be met. So just to put that into dollar terms, this year's annual budget for the Ministry of Health in Nepal is about $405 million. The cost to the government of Nepal to support rural dental clinics of the kind that I just described in all 3,500 of its health posts would be about $6 to $7 million a year. That would bring appropriate, and I'm going to say evidence-based dental medicine to 20 million people living in rural Nepal. Now, I did say evidence-based, and I know that's the thing that everybody is wondering about here right now. Where is the evidence? So let's back up a step. And on the first level, this model was developed based on the WHO basic package of oral care, which includes oral urgent treatment, atraumatic restorations, and access to affordable fluoride. And then as far as training, we've used the existing infrastructure with an agency local to Nepal that, as I mentioned before, was derived from a very well-established agency in Nepal, the United Mission to Nepal's 5-year oral health program, and led by a very well-respected dentist and researcher in Dr. Yi. So our approach really has been to take the existing evidence and work on translating that into a concrete delivery of care. And that has carried us quite far. That said, there's clearly at this point a great deal more that goes into actually implementing this system of care consistently and acceptably. And we're just now kind of turning the corner and getting into rigorous assessment of our implementation model. So we've begun partnerships and research initiatives with faculty here at UCSF, at UC Berkeley, at the University of Connecticut, and with Dr. Bethy Turton, who I think is here somewhere from the University of Putisastra in Cambodia, who is especially full of a great deal of knowledge about community-based dentistry in settings similar to ours. She's doing very similar work in Cambodia. So our first assessment looks at outcomes of ART restorations, anywhere from 6 months to 6 years old, that were performed by our technicians. And we compare those to the results that have been documented by conventional dentists in prior studies. This study it's still being written up, but it demonstrated that these technicians are successfully managing carious lesions that would otherwise have gone untreated. So we have measurably positive outcomes being provided by rural dental technicians. And in human rights terms, we're seeing steps towards that higher attainable standard than what previously existed. Can the outcomes still be improved? Absolutely. And this study is allowing us to measure these clinics against accepted standards and protocols and to specify where those improvements can be made. In terms of where we go from here, The infrastructure that we have now in Nepal includes about 20 field staff and roughly 50 schools, and that has created a wonderful opportunity for collaborative research and evaluation. So this is from our study this winter with Dr. Karen Sokol and Dr. Madhurima Ganguly. Oh, I see them up there now. And a very lively team of students. And because our project is so community-based, on one hand, we were able to offer insights on research instruments and methodology. And on the other hand, our village teams had this fantastic opportunity for professional development. They assisted with data collection, they provided all of the treatment in the fields, and they were able to do so in a way that, through this partnership, actually enhanced their legitimacy in their villages where they are trying to address this problem. And for students, it's an opportunity to get exposure to a community-based model that is designed and led by local people, which is quite different than the typical model that students might see when participating in global oral health work. So our hope, of course, was that this experience would kind of provoke students to think about things differently, and based on the feedback that I've gotten, I would say it did. I want to share one anecdote about how this collaboration played out in a village called Hansapur. Hansapur was the one place we visited with the research team where we were not already working, so there was no dental clinic. We didn't have any field staff there. It was a totally new area. But it was our clinic staff who treated patients. Our team leaders were involved with all of the data collection and the educational pieces. And after that camp, it was actually on the same day, leaders in Hansapur approached us and asked whether we might co-invest with them in a new dental clinic in their village. That is the first time that that's ever happened in 10 years, that we had a community come to us, not just asking for the program, but ready to invest their own resources in launching it from the beginning, rather than taking it over later on. And I think that the reason is that they saw the work of Nepalis from other villages, and the need for services was clear when 350 people showed up. And they were motivated to mobilize the same resources in their own community. And this takes us to one last point that I'd like to offer about the role of research more broadly and its strengths and weaknesses in addressing global health disparities. And I admit, I struggled a little bit with how to phrase this for this presentation, but given that I come not from academia, but from the perspective of communities in Nepal, I think it would be remiss not to raise this issue. And I think you'll probably see where I'm going with provoking some discussion on this topic. Having learned a lot about the healthcare environment in Nepal, I've observed that it's generally the job of experts to set research agendas, design methodology, analyze data, and interpret results. And there are important reasons for that structure. It serves a critical function in developing certain kinds of knowledge. But underserved people, and especially those who may be the targets of that research, often don't appear to have a voice in that process or the interventions that get designed from it. And in a way, I think that's the main reason that I'm here talking to you today. It's my belief that if we really want to address major disparities in global health, we have to set research priorities with input from communities that are affected by these issues. We need more power sharing, we need application-oriented studies, and we need use of participatory methods that leave the affected communities with ownership over the outcome of research studies and the information that is generated. Now, I did not invent the idea of participatory research, but it's not the dominant paradigm. So what I'm getting at really does in some ways represent a paradigm shift. But we need a paradigm shift, because there's no reason for 20 million people to be denied access to basic services that, with some imagination, are entirely possible to create. So I said at the beginning of this talk that I was going to give an example of a rights-based model for oral health care delivery in Nepal. And sometimes I think we make kind of an assumption that we have to make trades between some of these different factors that you see here, like quality and availability, so that when healthcare is adapted for a low-resource setting, that may be implicitly seen as a concession. And I'm not sure there's evidence for that unless it's occurring without innovation to address the quality of care in the new environment. Because what we really need to be looking at and studying is the change from what was there to what's been created from the point of view of the people being served. So in that spirit, I want to return to something I talked about in the beginning before I finished, which is the value of knowing nothing. Believe it or not, after all this stuff I just showed you, this photo here, which was taken quite recently, kind of represents a typical day of work for me when I'm in Nepal. This is me with a woman I've lived with in Nepal for the last 15 years in that same house. A lot of my job consists of saying, hey, everybody, we should do something. How about this? And then people saying, that's a terrible idea. But how about this? So, a lot of my job is still what it was at the beginning. It's still listening. It's still chopping wood and carrying water in baskets and developing a connection with the life that people live in rural Nepal. It's basically just empathy. But what I have also been able to apply to that empathy that everybody in this room has is a different point of view and access to the rest of the world. So when I'm in Nepal, I offer contrast. And I think that this is a generalizable kind of creativity that we all should be seeking. It doesn't come out of a power imbalance. It comes out of a clash between opposing ideas of how to define and solve a problem. And not just between all of us here together, but between like the random American and a bunch of Nepali farmers. That whole conversation, including ideas from all of those different places, because that forges something that is present to the problem at hand and relevant to the context. So we're probably not going to solve this problem by transplanting bits and pieces from one thing into another place. We have to start here. And while a lot of things have not worked in this process, I could do a whole second presentation on things that were terrible ideas. What has worked has done so because it builds on existing science, which so many people here in this room have contributed to. But there's also no attachment to ideology. We're looking for what works, for conditions that give people a choice and dignity. That is human rights in healthcare. So I'll end here. These are people peering into the Sindri Clinic on opening day, and I really love this photo. This is their clinic, it's their space, it's their technician, their resources, and there's so much available to us if we can start with this notion that it has to be doable. So in that spirit, I just want to thank a few people. There's a lot of ideas that have gone into my talk today, but really the credit goes to these folks, all of our technicians and clinic assistants and team leaders, our office staff, who sometimes hike 2 hours to work up a mountain in the rain. That actually really happens in their real job. And my co-founder, Govinda Paudel. I also want to thank my parents who came all the way here from the East Coast, which is actually not that far because they've schlepped all the way to Kaskikote, Nepal, not once but twice. And this project would never have come this far without them. So thank you so much for having me here today, and I really look forward to your comments and questions.
Thank you so much for this amazing presentation. I mean, you are a true ethnographic researcher, so congratulations on the accomplishment done there. I want to ask you, what do you think contributes to the sense of ownership that the dental technicians develop versus the dentists that come to work in Nepal from the outside? And what can we learn from this in terms of continued national diversifying the healthcare workforce to improve access across our own communities?
I think the first thing is that we listen to them. We give them the job. And then we have a whole bunch of frameworks and guidelines and support systems, but it's a conversation. And so they don't have that sense of ownership. You like to think that just by setting that structure up, people will come in with the feeling of ownership, but that's something that you kind of cultivate. It doesn't just, it's not like a part, like a brick that you put in and then it's there. So I think it comes through the process. And some of it, we've learned to structure in. We've found things that professionalize and kind of validate that sense of identity are really important. It was our technicians, one of our technicians, who really took this job seriously and made himself a white coat and started wearing it every day. And we thought, that's a great idea. We should do that. We should increase that. So some of it is recognizing those opportunities, and then you learn to do more of them and kind of build it in. But I think a lot of it, aside from the structural pieces, which it's community-based, it's appropriate and relevant to the environment, it's designed in a way that accounts for the reality of the local systems that they're in. So you create a structure that's at odds with that, and people aren't going to feel ownership. They're going to feel like they're doing something for you. But then it's also kind of the ongoing process of adapting and listening and finding those cues to reflect back. Like, both you have this ownership, but also you have this responsibility. Because people don't always want both of those things at the beginning. So it's a little bit of a dance. And I think that that's a lesson that we can apply generally. Even just the concept that it's not a formula, that it's something that has to be nurtured, is itself, I don't think, always the predominant view of creating local ownership. I think it's tend to be thought of as like an ingredient that you put in, like a certain amount of ownership, and it doesn't work that way.
Thank you.
Thank you so much, Francisco Ramos Gomez at UCLA. I commend your amazing work.
Thank you.
You're an amazing inspiration for so many of us. I really want to get your comments about, we've been trying to do this in Latin American countries with some success, but one of the biggest barriers we see is that we have not been able to convey this multidisciplinary approach that is so important and so for your success to ministers of health, especially on the issues of social justice, equity, and human rights.
Mm-hmm.
To bring the issue of oral health as a benefit for all is something that's such an essential part of this to be a success. And how can you envision this to be the community involved, a partnership with the community has to demand this social justice issue? Is it our groups of global oral health? Mm-hmm. I mean, how can we advance our advocacy to bring oral health as an issue of human rights, which is what you presented, which is essential?
Yeah. I hope to figure out a quick answer to that question because it's going to make my life a lot easier because that's a question that we're trying to work on. And my best answer is it's all of those things. I mean, at the policy level, it's lobbying. So, what is lobbying involved? It's everything. You have to figure out who the key people are, the different groups and their interests. For us in Nepal, there's a huge number of cultural pieces and sort of contemporary politics. Like the government in Nepal sort of changes its structure and its format and its motivations every week. There's a strike, there's this, there's something, there's a revolution. It's like hard to keep up. But you just have to kind of, stick with it in our context. And I think to a large degree, this is true everywhere. There's a lot of cultivating relationships, a lot of drinking coffee. There's a lot of being put through the paces of people don't answer your first 20 phone calls and letters. They want to see if you're going to keep sending it, if you're going to keep showing up. So you just keep showing up, you keep doing it. And then you kind of build your case from different sides. In our case in Nepal, I felt, and I still feel very strongly, that we couldn't rely on that process to succeed before starting to do something about it, because those two things have to happen together. So we're at the place now where when we go and present to policymakers in Nepal, and we get a lot of pushback from the Nepal Dental Association in Nepal, which I think is not surprising. So I was in a meeting, last summer there's somebody whose job is actually called the Oral Health Focal Point in the Ministry of Health in Nepal, which I just think is like an amazing job title, the Oral Health Focal Point, and then like the people from the NDA, and we presented from them, and I was with my program director, and a lot of the presentation was in Nepali, and then people were kind of excited until they really saw what we were getting at, and then they just went crazy, which we were ready for. We knew it was going to happen because we thought about this a lot more than they have, to be honest. So some of the questions we were really expecting, but our answer at that point, we were able to say, you make some important points. We want to make sure these technicians are doing a good job. We want to make sure they're safe. If you have concerns, please come out to our clinics. Do an evaluation. Tell us what they're not doing right so that we can improve it. But let's not judge them sitting here in this room. You haven't seen technicians that have gone through the process that we put our technicians through. So I think it's some of both. It's like we needed the practice there as part of our advocacy. But you can only get so far with implementation if you don't have the policy, if you don't have the literature, if you don't have, I think all of those pieces are needed, and I just think of it in terms of lobbying, It's all of the same things you would use to lobby an issue anywhere.
So over the years, over the 7 years of putting on the symposium, we've been very fortunate to have lots of fantastic speakers and lots of support from the academic community, support from our students, as well as support from organized dentistry. We've had quite a few presidents of the California Dental Association join us, as well as presidents of the American Dental Association. And this year, it's my great privilege to introduce Dr. Gary Roberts, who is joining us from the American Dental Association. He's the president this year, and he's going to share a few thoughts before we get going with the rest of our keynote presenters. So thank you, Dr. Roberts.
Thank you. Before I get started, one thing I want you to understand that Dr. Nash and I do have in common is that we both speak the same language. He's the only one I've heard this morning that's really speaking English. But good morning, and thank you, Dean Featherstone and Dr. Chaffee and all the faculty and staff, and all your students here at UCSF. And thank you for inviting me to be here with you today. Delivery of quality oral health care to all people is a universal aim of the profession of dentistry. A healthy mouth is the right of every human being. We are committed to a tradition of preventive care. Our goal is to provide dentists with the best possible tools and environment to help them excel in their careers while being leaders in their communities. But all this is supported by the belief that individual patients and entire populations deserve the highest quality of care, especially the poor and the underserved. For example, we must all work together to ensure that the one and most important and cost-effective strategies to prevent oral disease, community water fluoridation, continues to be promoted throughout this country and throughout the world. Despite being one of the top 10 public health accomplishments of the 20th century, opposition to community fluoride is an ongoing battle that we all must fight together. We face a crisis in connecting patients with oral health care, and there's little debate about that. There is, however, debate about how to solve the crisis. But I'm optimistic because bold solutions often are generated in times of urgencies. But we must have a word of caution. Urgency can lead to the proposal of Band-Aid solutions rather than long-term sustainable solutions. And here, history might offer us some guidance. How many students do we have here today? Great. I'm so excited. I'm so jealous of you. Y'all are going to do things in your career I've never even dreamed of. Okay, students, imagine that you were studying to be a dentist 75 years ago. Way back, even before Dr. Nash and I were born. It's 1946. The country and much of the world is just recovering from the Second World War. They're rebuilding and trying to return to normal. But the war shed a harsh light on the state of dental health in the United States. Almost 1/4 of the men who joined the Army either had or needed dentures. We can speculate that the dental health of the older populations was even worse. Prompted partly by the war, there was a robust national debate on how to improve oral health on a nationwide scale. On the side, there was one argument that pushed to make universal dental care a reality as part of an expansion of a newly program called Social Security. On the other side, there was the belief that in order to solve the dental health crisis, we needed to address the underlying causes. We needed more research, and we needed more preventive education. The country followed the road toward education and research. And with the benefit of hindsight, I think we made the right choice. So where are we today? Most Americans keep their natural teeth for their entire life. The National Institute for Dental Research, established by President Harry Truman, helped catalyze investment in dental research. Most American households began to realize that they played an important role in maintaining their oral health through constant home care. Around the world, organizations like the FDI and the WHO, and organizations represented by some of the speakers today, are making steep investments in science, education, and prevention. As we develop solutions that address the dental health crisis that exists today, it's important that we learn from the past, that we implement prevention solutions with long-term viability and scalability, which addresses the root causes of dental disease and disparities, while still providing care for those who need it now. Efforts are being made by dentists around the world to address the crisis, and I believe dentists are the key to the solution. Students, you will soon be fully licensed, practicing, fully trained dentists. And you will be supported with organizations like the ADA, which will help you connect patients in need of dental care to dentists who can provide it, while seeking to educate communities about the importance of oral health to overall health. Maintaining good oral health is an important part of all people, regardless of age, income, or education. For example, many people without dental coverage don't seek treatment until their pain grows so severe they wind up in an emergency room, where the problem is virtually never solved. We're working with hospitals and now with the American College of Emergency Physicians to get patients out of the ER and into a dental chair. ER referral programs now exist in all 50 states, and new programs are coming online every day. A soon-to-be-released study will show us that ER use is declining for patients with dental issues. We have a new team member called the Community Dental Health Coordinator. They are specially trained, and they reach people who typically do not get dental care for a variety of reasons like poverty, transportation problems, language, culture, and a lack of understanding of the importance of oral hygiene and regular dental visits. They work in communities not unlike yours to increase oral health awareness and to connect individuals on a regular basis to get dental care and establish dental homes. Efforts are also underway to advocate for increased dental health protections under Medicaid, to expand the number of communities who fluoridate their water, to provide charitable outreach and to facilitate connections between dentists and FQHCs, and to collaborate with other healthcare professionals and organizations so that families understand that good oral health is crucial to their overall health. All these efforts expand care for vulnerable populations, and each of these solutions share a similar key. Every person, including the poor, the elderly, those in rural communities, Native American lands, everybody gets the same high-quality care that you and I receive, and that care is provided by a licensed dentist. Students, soon you will graduate. You'll be fully trained and licensed, and you will be uniquely equipped to provide the care that is so needed by so many people. My challenge to you is this: how will you use your specialized skills to address the global oral health crisis? And how will you use your training to make a difference? Thank you for letting me share this time with you, and I know you're going to continue to have a wonderful symposium. Thank you very much.
We might have time if there's any one question.
Thinking back at the previous presentation and your comments in ADA's position that it is the dentist who facilitates the change in oral health. What is your reaction to our previous presenter, where in a country where there's no dentist, there was virtually nothing, and yet the impact is tremendous?
I think that they are doing wonderful work in Nepal. And the difference is, in the United States, we have dentists. 12 years ago, we were graduating 4,000 dentists a year. This year, we will graduate 6,300. Marko Vucevic, the head of the Health Policy Institute, has predicted over the next few years, up until 2035, we will have a net increase of between 2,000 and 2,500 dentists per year. So the manpower is there. The key is getting the manpower to those who need it. The key is navigating those patients to those people and getting that care done.
Thank you.
Thank you.
Could you please comment about reimbursement for dentists? Would you think, or do you see, or in our lifetime, we're going to see a change of reimbursement of patient fees?
I think we're already seeing a change. I think insurance and the government are already changing the way that we're reimbursed. We're already seeing some pay-for-performance type things coming in. I was in Arkansas last week and talked to the head of Delta Dental, and for the first time this year, they were sending out, I think, over 2,300 checks for pay-for-performance for people who were doing things that they thought that they should do and care that children should get on a regular basis.
Yes, thank you.
Okay, well, thank you very much.
So now I'll welcome to the microphone to introduce our next speaker is Dr. Stuart Gansky.
Thank you. Thank you, Dr. Roberts. My name is Stuart Gansky. I'm the director of our Center to Address Disparities in Children's Oral Health here at UCSF, sponsored by NIDCR. It's my pleasure to introduce our next speaker, Professor Dana Hughes. Professor Hughes is a member of the Philip R. Lee Institute for Health Policy Studies, of the Health Force Center, and of the Department of Family and Community Medicine. She's worked on the Hill as for members of Congress and for the Children's Defense Fund before earning her doctorate in public health at UC Berkeley. And she's been here on the faculty at UCSF for a number of years, and today she's going to be sharing with us results of an evaluation study of a multi-site mixed methods evaluation of 6 innovative workforce programs in multi-sites for oral health prevention. So please join me in welcoming Professor Hughes.
Well, for starters, thank you again for having me, and I get to share with you some early results from a study. I'll spend some time describing it and giving you some context, but I want to start by acknowledging 2 of my colleagues who work on this study with me, and that is Joanne Spetz, who's here at UCSF, and Natty Parat, who's at UCLA, both of whom are major players in this study. I want to begin with a few figures that are known to you, undoubtedly, but they're helpful for providing some context, and this is the context within which the Robert Wood Johnson Foundation decided to fund this study. So for starters, this is not unknown to you that, that dental disease is the most common chronic disease among children. It's also obviously a huge issue among adults as well, that the most common cause of tooth loss among adults is periodontal disease. So it's not insignificant that we are even concerned about dental disease. In 2000, this report came out by the Surgeon General, which was one of the first major spotlights on issues around oral health in this country. Among its many contributions were some of the points that it made that Dr. Roberts was just referring to, and that is the huge disparities in oral health status among many populations in this country, including racial and ethnic minorities, the poor, rural, disabled, and people in rural areas. The report, among other things, talked about how this issue of disparities was in large part a function of problems of access to health care. This is kind of a busy slide, but it shows you the proportion of the population in the United States over a number of different years who needed but were not able to get different types of health care due to cost. And you can see that the second set of bars on the left is dental care, and it's then while there was a little bit of a dip in the last 2 years on this slide, obviously the trend was actually on the incline. Another way of looking at this question of access is looking at health shortage areas. And this is a slide that just, it too is kind of busy, but it shows different degrees of shortages for dental care across the country. The orange is geographic high need. Well, in any case, there's three different things that are represented here, and I can't even see it well enough to tell you. But there's geographic high need, and those are areas that have been designated as a particularly high need based on a number of criteria. The second is geographically designated as health provider shortage areas for dental care, and then there's, within geographic areas, there's populations that are requiring dental care. So you can see that, that there's many ways of looking at this question, but there's no doubt that we have a serious problem of access in this country. So the Robert Wood Johnson Foundation has had some interest in this question of access to dental care for a number of years. Their primary interest is in children, but they're interested and concerned about all populations. They funded the study that I'm going to be sharing with you in 2014, but there was a number of years of work that went into it prior to that. I think 5 years beforehand, they put out a call to the oral health world in the United States asking for examples of models of innovation in oral health workforce that people believed contributed to improved access to preventive services. They received about 100 nominations, of which they whittled down to 25. They then put those 25 to a test of evaluatability. It went through a very, very rigorous 2 or 3 year study. Of that 25, they came up with, there were 12 projects that were identified as innovative and that could be evaluated, or potentially innovative and that could be evaluated. And the question was, what was the contribution that they made to access to preventive services for children? So we came on the scene, and we had these 12 sites. We brought together an advisory committee, and along with the Robert Wood Johnson Foundation, we established some criteria and came up with a final set of seven sites that we're going to be studying under this overall evaluation. There were 4 domains that were identified beforehand by the foundation that they wanted covered: the effectiveness of the intervention, the role of workforce intervention in producing whatever results, the generalizability of the model to other populations and other communities, and then finally a question of sustainability, both within the project itself that we were looking at, as well as if it was to be spread or replicated in another community. So what I'm going to do is to tell you a little bit more about the study and the design, to give you a brief overview of some of the projects that we've looked at, to share with you some of the preliminary findings, and then discuss a little bit about the implications. So the study sites. The first is in Southeast Alaska. It is an oral health project operated by SEARCH, which is the Southeast Alaska Regional Health Corporation, an organization that has served Southeast Alaska, as you can imagine, but it also has comprehensive medical and dental services provided to this population. There are 2 sites in Minnesota. One of them is Children's Dental Services, and the other one is PICO, which I'll fill you in on what that acronym means, but it's a project of a private not-for-profit dental provider called Community Dental Care. The fourth is called CHC Mobile, which is a mobile dental program within a large community health center serving all of Connecticut. Then there are 2 programs that are within pediatric offices, one in Washington State, Group Health, and the other United Healthcare in New Jersey. I'm not going to focus on those very much in large part, well, for two reasons. One is because of time, but the other is because a lot of the analysis, at least of the quantitative analysis, is being conducted in-house for reasons you can imagine that they weren't that anxious for us to have access to their data. But we know a fair amount about their model, having done site visits there. There is a seventh site that we are treating somewhat differently, and that's the virtual dental care model out of University of Pacific that's here in California that you're probably familiar with or at least have heard about. We are doing a case study of that, but not the same kind of analysis that we're doing of these other sites, only because the period of time that we're trying to look at across all the sites, there are very little data that were available. The virtual dental home is being reimbursed in California by Medicaid, Medi-Cal, so there are data currently and moving forward, but there weren't historically. So we're limited to a case study. So what are the innovations that each of these are associated with? In two of those, both Search and PICO, both are models in which they use community health centers around the prevention, the provision of preventive services and improving access. Two of them, CHC Mobile and CDS, are both mobile dental care programs. And Group Health and United Healthcare are the provision of preventive oral health services to children in pediatric offices. And I should just say that, and I'm happy to describe what we know about those later if you'd like, but these are often described as described as pediatricians providing preventive oral health services. And in fact, at least in these two cases, that's not really the case. Pediatricians, as a part of their overall physical exam, are much more conscious now, and they actually do a full observation of the mouth. But fluoride varnish and any other kind of preventive services provided by a medical assistant or a nurse. So it's a team effort that provides preventive services in this context. So we designed this to be a mixed method study, both qualitative and quantitative data. The qualitative data were collected through a 2 to 4 day site visit of each of these sites. We developed a semi-structured interview protocol that was standardized across the sites with some variation to accommodate the differences. We conducted between 10 and 20 interviews per site. We did some observation as well as document review. In addition, we're conducting analyses of each of the program's dental records, their EDR, for utilization and some outcome data. And for Minnesota, Connecticut, and Alaska, we're also examining Medicaid claims data. We've struggled some to also look at Head Start oral health data, and for reasons I'm happy to discuss later, that's been a little bit more of a challenge, but to the extent that we can use that as another source for our triangulation, we are using that to create a complete picture. So let me just start with some descriptions of each of the programs. So as I indicated earlier, there is Search, which is Southeast Alaska, and they have a robust dental service delivery model that has been in place for about 10 years. And it has two major features. One is that that distinguishes it from many others. One is its team-based care, and within the team-based care in its entirety, meaning the dentist, hygienist, dental health therapists, and primary dental health aides, as well as dental assistants, are on board providing services at each of the full clinic sites. In Southeast Alaska, there are only a handful of full clinic sites in the regional health centers. Sitka and Juneau are two of them. But you'll find at any of those sites a full complement of these teams working together. There then are village clinic sites, and then Southeast Alaska is very, very rural, and there are many communities that are in isolated islands, very small, that can't support a dentist, let alone a hygienist or certainly a clinic. And so they have smaller dental clinics that are either run by dental health therapists or these primary dental health aides. Then a dentist and or a hygienist come by on a rotating basis to these more remote areas, and patients who need those services by those individuals are scheduled for a day or two and seen one after another. I want to speak a little bit more about the primary dental health aides, because this is where we've placed our focus, in part because, or actually large part, because their job is defined as promoting prevention, and primarily among children, but prevention. So, and there aren't very many equivalent health providers practicing in other parts of the country. So it seemed that this was an interesting model to look at. There are actually, there's a group, the primary dental health aides have a number of different functions within a community. They provide dental health education, they provide preventive dental services, and they do, including fluoride varnish, x-rays, prophies, and sealants. And then they provide a fair amount of instruction on oral hygiene as well. They also are responsible for the scheduling of the dentists and hygienists when they come through. They have a number of other functions within the community where they go to schools and provide community education to children and to teachers, actually. And they go into Head Starts and other community settings to provide education and some basic preventive services. There's a tiered training system for primary dental health aides, but it's a fairly minimal process. Primary dental health aides, by definition, come from a community in which they're going to go back and work. Alaska has a very robust community health worker program that's been in place since the 1960s, and they have extensive certification and training and licensing procedures associated with it. And PDHAs are under the umbrella of that agency within Alaska and who's responsible for their training. So there's a PDHA 1 for whom there's about 80 hours of training on topics around health promotion and disease prevention. They're trained in basic dental procedures, and they have a preceptorship of around 40 hours. There's a PDHA 2, which is a little slightly higher level individual, and oftentimes a PDHA will will be working in the community and decide that there's either higher need or they want to advance, so they'll go back for some additional training. And in this case, they receive some advanced diagnostic training, such as intraoral camera use. They also specialize in either sealants or prophylaxis, radiology, dental assisting. They, too, are encouraged to go back to the community in which they came and practice and serve their community. So I want to turn now to another program, and this is PICO. And PICO stands for Program to Improve Community Oral Health. And it's we had a little bit of a struggle when we first tried to understand what this program was all about, because PICO was actually, in all the references we came up with initially said that it was defunct, but then we were studying it, so it was a little bit of a puzzle. It turned out that PICO was the name of a coalition that had been established in the greater Minneapolis area in the 80s and 90s that was promoting oral health education, but also funding for access to oral health services among underserved populations. The coalition is defunct, but this program assumed that name. So as I indicated, CDC, Community Dental Care, within which PICO is housed, is a not-for-profit but private dental provider. It has, I think, 4 clinics in the greater Minneapolis area, St. Paul, Minneapolis, Twin Cities. PICO targets low-income and minority families and refugees and immigrants. And as you may know, that in the Twin Cities area, there's a large number of immigrant populations and refugees. And Community Dental Care became aware of the fact that these were populations that were simply not being served. And when they were being served in majority culture methodologies, which were not terribly effective. So they created this program in which there are individuals from those refugee and immigrant communities who are trained as health educators and in some prevention, as well as including conducting risk assessments. And they form PICO, which then provides these services to these populations. So at this juncture, they have 5 of these individuals working in the Twin Cities. They are specially trained in culturally appropriate risk assessment and then and health education. They also use motivational interviewing techniques and goal setting, and then they have individuals and families come back to them and check how they're doing on their goals. They also provide additional services in school settings, such as education to classrooms and teachers and the like. The third program I want to talk about is CHC Mobile. CHC Mobile is housed within what, as I described earlier, a very large community health center program in Connecticut. CHC was established in 1972, but its first program was dental care, and now it's a comprehensive behavioral, medical, and dental health community health center. They determined early on that there was a mission related to dental care that they had, which was, you can read it, to promote and enhance the oral health of children, youth, and adults, particularly the uninsured and underserved, and to assure their access to comprehensive primary and preventive oral health services. So they've decided to fulfill their mission by bringing services to where the children are. We heard about this earlier, about that this being, oops, sorry. Of course you should have been able to read that. Sorry about that. Somebody should have told me. So they have a robust mobile dental health program that they bring throughout the state, which includes a combination of fixed chairs in some sites, as well as these mobile units, and I'll talk about that in a little bit. So they have within their mobile program 3 different service delivery models. The first and the largest of them is mobile preventive services. And these are comprehensive hygiene services, cleanings, fluoride, x-rays, et cetera, provided by dental hygienists in mobile or fixed school-based or non-traditional settings like Head Starts and the like. What's important about the mix between mobile and fixed is that they prefer to provide would prefer to have a fixed chair in every setting in which they provide care, but they don't have the resources, as you can imagine, to do that. But they do place a fixed chair in settings like a large school or a school with a very high demand. And they'll have usually staff there most of the time to provide services. But most of the care that they provide is through these mobile units. They also have a component that is mobile restorative care. This has gone up and down over the years in terms of its robustness. And in fact, when we visited, it was essentially non-existent because it requires a dentist, of course, and other staff to travel throughout the state to provide the care. And they didn't have the resources. But when we were leaving, while we were there, they discussed the fact that they had just hired a dentist who would be traveling around this state to provide restorative care. They also support school-based health clinics, which exist in the state. There are, I think, 3 sites around the state that have large school-based health clinics in high schools, and they have fixed chairs in those sites with a full-time hygienist who works there. The dentist, when this dentist comes on board, or if the dentist is on board, will go to those sites on a rotating basis to provide care for restorative services. So this is a list of the kinds of services that they provide. You can see that it's a typical complement of hygienist services. The program also provides oral health coordination and outreach. Generally speaking, if they find that there's a child who needs more extensive services, they will make a referral to that child's own dentist, to a community dentist, or to their own clinic. And as I indicated, the restorative dental program is limited and only in some settings. Just to give you a sense of the scope of this program, they have currently 177 active sites. Now, these are sites where they might just go for a day, a month, but there are others where they're present much more frequently or even consistently. They have over 7,000 patients. Most of the services that they provide are in school settings, but they do go to some other settings where there are populations that are underserved and uninsured or underinsured. Just to give you a little bit more depth about who these people are, they currently employ 11 hygienists, 4 care coordinators, 1 dentist, 1 dental assistant, and an AmeriCorps volunteer. The equipment, this is the equipment that goes, that constitutes their mobile equipment as a supply cart, chair, compressor, sterilizer, x-ray. They have 13 full kits with some additional odds and ends that are available if things break down. And they estimate that it costs about $40,000 to finance each comprehensive kit. So finally, I want to talk about children's dental services. This is a very, very large provider in Minnesota as well. What's interesting is they were founded in 1919 as a dental provider for orphan children. Since then, it's gone through many, many different iterations and changes, so that today it serves low-income children and pregnant women throughout Minnesota, as well as some parts of North Dakota. Their primary focus is on cultural and ethnic minorities, and to make this happen, they have an incredibly diverse staff, of whom most speak at least 2 languages, if not many languages. Their population is also quite multi-ethnic, and you can see the distribution here of the current population. Now, what's really important about what they do versus, for example, CHC Mobile, is that they rely almost primarily on portable dental equipment. They do have 2 clinics with fixed chairs in Minneapolis, and they do have 3 sites where they actually place, they have semi-permanent chairs. But the rest of the people, the rest of their visits are with these mobile units that go throughout Minnesota, and they're very, very proud of their mobile units and the kind. And I'll share with you in a moment how extensive that these are. They also bring with each of the mobile units a multidisciplinary staff of dentists, hygienists. They have advanced dental therapists as well as dental therapists and dental assistants. They provide, this is also a distinction, they also provide full spectrum preventive, restorative, and emergency dental care through their mobile units. This is the full complement of services that they provide. And this is here you can just see the list of the equipment that constitutes their mobile unit. They have vans that are housed throughout the state that carry the equipment, geographically placed so that they can go to Duluth or they can go to North Dakota or service the Twin City area. But as you can see, that it's extensive, and obviously they would need this range of equipment to provide the services that they do. So, preliminary results. I want to share with you some of the findings that we have to date. So, the caveat, of course, is that we are still deep in analysis of both the dental records from these health centers, the programs, as well as the Medicaid data that we're looking at. But we can say a few things about all of them. So on a very, very top level, in terms of Southeast Alaska, it's absolutely clear from at least anecdotal evidence that the primary dental health aides have made a major contribution to improving access to dental services in the communities in which they serve. There's some evidence that they may also have contributed to reductions in disease. That too, of course, is anecdotal. But I was struck by Lori's presentation earlier about the culture of oral health and oral hygiene. And one of the remarks that we heard repeatedly from people that we interviewed was that the PDHAs had shifted the culture in the villages in which they were working so that there was an emphasis now not only on oral health and oral hygiene, so brushing one's teeth and flossing and nutrition, but people also, for the first time, saw themselves as going to see a dentist on a regular basis even before they had a problem. So this cultural shift was a major change in Alaska that's attributed to the PDHAs. In terms of CHC Mobile, we do have some preliminary findings from their EDR that has shown that there has been a steady increase for the clinic as a whole in the use of preventive dental services and the number of patients that they serve. And that numerically is predominantly attributed to the mobile dental program. So when you compare, we compared the overall changes in dental patients and preventive visits, broke it down by those that were seen within the clinic versus the mobile unit. The increases that have occurred over the last 15 years are almost solely attributable to the expansion and the reach of the mobile clinic. In terms of CDS, which is the program that serves in a mobile clinic across Minnesota, we also have at least early evidence that that too has improved access to oral health, including prevention, but not exclusively prevention. That they today have 34,000 patients, both in the clinic within Minneapolis, but also but primarily the bulk of their patients are in the outskirts of Minneapolis. And that's compared to 2,000 patients just 16 years ago. So they've done an enormously good job of expanding their programs to populations that need the care. In terms of PICO, I would say that it's both too early to tell what the impact of that program has had. In part, we're struggling a little bit about separating out a unique contribution that the PICO program has made as distinct from the other kinds of dental services that the patients receive through the dental through the clinic overall. But at least anecdotally, the people that we interviewed talked extensively about how, the importance of that program, at least in providing culturally appropriate and linguistically suitable services to a population that was obviously underserved, if not unserved previously. Now, I want to note that we, of course, are very interested in understanding, as is our charge, whether or not these models have led to any improvements in access to preventive services, primarily for children. But we're also interested to know whether or not that any of those improvements in access have had any impact on disease. And we've been able to, we're beginning to chip at that question. I don't have the results exactly for you right now, so I'm asking you to stay tuned. But I think, the reason why I'm underscoring that point is that even though our charge was really around access, we acknowledge that access, of course, is important but not sufficient if it's not leading to improvements in oral health. So the other dimension that we needed to look at in terms of these programs was not just effectiveness and impact, but was their generalizability. And I think at this juncture we can say that each of these models, with the exception perhaps of PICO, because we just don't have the information yet, offer promise in communities that they serve, and potentially as examples for other communities as means of using alternative workforce models to improve access, particularly among populations that simply don't have access to dentists. The transferability of these, though, I think is a more difficult puzzle somewhat, because these are very specialized for the most part. Many of them are designed specifically for a population that is underserved. And so to the extent that there are other populations that mirror those populations, these may very well be transferable, but that's a question that we have yet to tease out completely. The biggest question, though, of course, relates to sustainability, even for these programs. As you can imagine, because all of them target low-income populations and either uninsured or underinsured populations, there's high proportions of them are Medicaid patients. And even last year and the year before, when we did our site visits, there was a lot of concern about the sustainability of these programs over time, not because they were concerned about what was going to happen to the Medicaid program, but simply because because they have populations that are changing constantly, and reimbursement rates are uncertainty about reimbursement rates. But obviously, given what's happening in Washington these days, there's even a bigger question mark about their sustainability, since the long-term plans for the Medicaid program are up in the air. And depending on how that plays out, there could be some major implications for these programs and their ability to even keep their doors open, let alone to spread their models elsewhere. So in terms of implications, I think that we still have to finish our work to be able to paint this picture comprehensively, but there is suggestion based on what we know so far that these delivery models do hold some promise, and that innovation in the way in which one configures the workforce can leverage a wider range of workers to provide education, screening, community outreach, and direct preventive services. Again, financing remains the major question that we and they have. This is a quote from a woman in Alaska who started off as a primary dental health aide, and then after working in her community for a number of years, then did some additional training to become a DHAT. And when we asked her, well, if you could communicate to others about the importance of your work and what kind of contribution you make, she said, well, I just want others to know that I don't want to take their jobs. I just want to be part of their team. And together we can tackle this epidemic. Thank you very much.
Hello, Jenny Gallagher from King's College London. In relation to the whole area of access, and I think it's lovely to see this issue being researched, one of the issues can sometimes be that when you create a new model of care, the people who actually get access are the ones who might have worked their way into other services elsewhere, and actually some of the sort of slightly more affluent of the dispossessed, in a sense, will be the ones who will make their way to services. And I just wonder, have you got any sense, or are you able to capture within the data some of those who might have made their way to other services anyway? Because when you look at the growth in uptake, how much of that is growth of people who would not have accessed services versus those who might manage to make their way through to the service? Does that make sense?
Mm-hmm. Yeah.
Thank you.
I think these programs have very limited resources, so they very deliberately do the analysis to assess whether or not they're duplicating services or they're going into communities where there's needs. So that's one dimension. So they are basing their decision-making on some data that demonstrates that there's unmet need there. The other is that when there are issues that are identified, for example, in the mobile units in rural Minnesota or in Connecticut, the first point of referral is to a medical or dental home. Do you have a dental home? Because we'd like to send you there for some treatment. Yeah. And by and large, the families do not have dental homes. Yeah. So,
thank you.
One of the keys to sustainability of all this, as you indicated, was funding. So assuming that Medicaid continues, which may or may not be a valid assumption, but we'll assume that, are these programs here able to be sustainable with the level of funding that they're getting from Medicaid? Mm-hmm. Because most practitioners will not deal with Medicaid patients because they can't make ends meet. So right here on this campus, we're losing about $100 per visit on Medicaid patients. Mm-hmm. So would you like to address that?
Sure. Well, they have an advantage in that most of them are federally qualified health centers, so they get an encounter rate, which is a much higher rate than what your dentists are getting here in the clinic. And in Southeast Alaska, for example, the primary dental health aides and the dental health therapists, they tell us they pay for themselves because of the periodicity schedule that's allowable in Alaska for visits and the way in which they can bill. There's no additional outlays for them, but nonetheless, there's always the funding is always a concern. It's always fragile, and there's always a concern that all of those advantages that they have from a Medicaid financing point of view could vanish at any moment. So.
And of course, several of the things that are being provided are not covered by Medicaid anyway, so that's another issue.
Right. And so in those cases, then those have to be supplemented by other means. In some cases, those are grant funds. In some cases, they are from foundations or other kinds of like local charitable organizations. But for the most part, they try to finance these services based on Medicaid funding.
Thank you.
Okay.
Okay, thank you.
Okay, thanks.
Good. Okay. Thanks very much, Beth, and thanks very much, Ben, for the invitation. I'm going to talk more about the what rather than the who, particularly about prevention, the cost effectiveness of prevention for very young children, this NICPIT trial. So this is 7 years worth of work, £2 million in 10 minutes, so we'll see how we get on. So when we were planning this trial back in 2008, obviously caries is a significant public health problem. We carried out the trial in Northern Ireland. At that time, there was a 61% prevalence of caries in 5-year-olds, so a very significant problem. Across the world, particularly in the UK now, very topically in the UK, there's a move to reorientate dental services to have a much greater emphasis on prevention. And to that aim, this document was produced at that time by our Department of Health, delivering better oral health and evidence-based toolkits. And a lot of the interventions we tested in the trial are advocated by this. This is now in its third iteration. And we were predominantly interested in this question: can we keep as many children free of caries as possible? And by caries free, I mean caries interdentine. Cavity-free, I suppose. And this is based on some observational work done with 750 children in 50 dental practices that we followed up for 3 years. And we found the majority of children were caries-free at their first visit, and about a quarter of these children developed caries over the subsequent 3 years. 16% of children already had cavities, caries interdentine, at their first visit. And about 3/4 of these children developed more cavities over the subsequent 3 years. And no matter what age the child developed caries, it progressed at this same very rapid rate. And the outcomes, the human outcomes in terms of pain and extraction, were quite alarming. Once caries developed, children had a 20% chance each year of an unscheduled visit due to pain, 11% chance each year of an extraction, usually under general anaesthetic, and no evidence that restoration reduces the risk of pain or extraction. And we started thinking of these two groups, caries-free, caries-active, as two populations. And this is, I think, being supported by this recent study. It's just been published in Journal of Dental Research. And this is 6,000 children we followed up between the age of 6 and 16, multiple clinical examinations. And these are the disease trajectories of, in the permanent dentition, of children who are caries-free in the primary dentition and children who are caries-active in the primary dentition. And there's a 5 times difference at 16. So we wanted to keep as many children as possible on this lower disease trajectory. So the aim of the trial was to measure the effects and costs of a composite fluoride intervention designed to prevent caries in young children attending dental services. So it's a 2-arm, parallel group, randomized controlled trial, allocation ratio of 1:1, and we conducted it in 22 National Health Service dental practices in Northern Ireland. Children we recruited were 2 to 3-year-olds at baseline, and they were caries-free, and we followed them up for 3 years. The intervention had 3 component parts to it: fluoride varnish, free toothbrush, and free 50ml tube 1450 fluoride toothpaste, and standardized prevention advice based on the guidance I showed you earlier. And these three things were all provided at the 6 monthly checkups of the children. So every time they came in over the 3 years, so 6 times a year over the 3 years. And the control population received the same standardized prevention advice, again provided at their 6 monthly checkups over the 3 years. The primary outcome measure was this conversion from caries-free to caries-active states. Secondary outcome measures included number of episodes of pain and extraction, mean number of caries surfaces of teeth in those that developed the decay. There's a huge health economic component, and we also looked at safety. We estimated from epidemiology and activity data that about 47% of children would develop caries over 3 years. And we were looking for a clinically important and policy important difference of 10% between the groups. We assumed a 70% consent rate, 15% dropout rate, which meant we'd need to recruit and randomize 600 children per group. And we overachieved that. We randomized 1,248 children. Instead of 15%, our loss to follow-up was 12%, and this was evenly balanced between the group. The most striking thing of the trial is we had this amazing compliance rate. 87% of children in the intervention group and 86% in the control group attended all 6 of the 6 monthly appointments. This is a summary of the results. So we found a 5% difference in favour of the intervention in the primary outcome measure, but this was not statistically significant. There was a statistically significant difference in DMFS in favour of the intervention in those that developed caries. And you can see from a standing start, these kids developed a huge amount of caries over 3 years. There was no difference in extractions or pain, but the trend was in favour of the intervention. This is a summary of the usual trial caries metrics. So for all children and for just those that develop caries, all were statistically significant. And the total population, DMFS, there was a relative reduction of 34%, which equated to just over 1 tooth surface. Children with caries, as I said, 25% relative reduction and a difference of 2 teeth surfaces. Fluoride varnish was very safe, even in this very young age group. We had 10 children with very minor complaints, which could potentially be related to the fluoride varnish or were self-limiting. Health economics was a major component. So the mean difference in direct healthcare costs between the groups was statistically significant. So prevention was more costly than the control. And the mean cost per carious tooth surface avoided was £251 over the 3 years of the trial. The health economists did a number of sensitivity analyses, and they showed that skill mix reduced the costs of the intervention, but was still more expensive than the control population. And this, importantly, this doesn't take into account the possible financial incentives which would be necessary to achieve the high compliance rates. Because if we look at contemporary data from our National Health Service, about a third of children in 2014-15 received at least one application of varnish in England, and in Scotland, about a third of children received 2 or more. So it's a long way from the 87% we achieved in the trial, and compliance is really important. So interpretation, if you're a glass half full sort of person, the good news is fluoride varnish is safe, even in this very young group. We got a 34% reduction in population disease, about 1 tooth surface. Whether that's an important reduction or not, we can have a discussion about. And we got this 2 surface difference in DMFS in those that develop caries. So it shows that the intervention slows the progress of the disease once it develops. If, like me, you're a glass half empty sort of person, the most disappointing thing was that in the test group, even though we had 87% compliance, still over a third of children developed caries. There's no difference in pain or extraction. Health economics shows that prevention is not cost-free, particularly for a state-funded service like the NHS. And most disappointingly, it wasn't the step change we were hoping to find. And this step change is now an ambition of Public Health England. At the end of last year, they issued this statement: every child grows up free from tooth decay as part of every child having the best start in life. So I think we need to look at the cost effectiveness of our interventions, not just fluoride interventions. We need to look at sugar control. And also we need to look at incentives or interventions to induce changes in behaviour around those two interventions. And finally, as a public health dentist, I would like to see a shift of resources away from practice-based programs to community programs that we heard about at the start of the program. So I'll stop there. Thank you for listening. This is a thing I have to put up by the funders, and I'd like to pay tribute to the fantastic team we had in delivering the trial. Thanks very much for listening.
I think we'll hold the questions until all three of the panelists have given their talk. So our next speaker is Tope Ogunbodede.
Well, good morning, everybody. It's been a pleasure being here, and I want to actually acknowledge this program because it's truly global, and I think we need to emphasize that. And I'm saying that because I'm standing here today recognizing the contribution of Emeritus Professor John Greenspan for his contribution to my own university and to many of the schools that I also know, in Africa. And I also recognize that here this morning we have with us here one of the people who has benefited, from his magnanimity, and that's Foluso, who is here in this audience. And he had his, he was invited here, and he stayed a year because we had nobody in oral medicine at that time, and he has actually been able to train quite a number too. And I want to thank the Dean, Ben, and others for inviting me to this program. So I'm grateful to Professor Greenspan, to Deborah, to the Dean, and to others. Having said that, I want to go ahead now with my presentation, and I want to say here that my approach to this is going to be to talk about things that, ordinarily we have not been mentioning, which I think is very critical to the topic that we are discussing, this morning. We've talked about quite a number of issues, but I think the oral health personnel that we use goes quite beyond the kind of nomenclature that we've given to the people working in oral health today. This is my university in Nigeria, so welcome from Obafemi Awolowo University. I'm going to be talking about the worldwide perspectives on the dental care delivery system. Well, I'm going to, like I said, emphasize, the key issues that I think can be very different from what we have here in the United States of America. Laura was talking about the value of knowing nothing. But in most African universities and most African communities, we find that the people who actually brought in dentistry came from Europe or America. In Nigeria, the dawn can be traced to 1903, when a Canadian came to establish the first dental practice in Nigeria. other things have followed in that direction. There is a book which I have been privileged to write on the history of dentistry in Nigeria, and all those things that pertain to Nigeria, they are actually well documented, in this book. This is Nigeria with a population of 180 million, and we have 9 dental schools. But the point here is that most of the dental schools are located in the southern parts of the country, particularly the southwest. And then you have only 2 of the dental schools in the northern part of the country. This is quite common with other African countries. And the dental training institutions, they are mostly located in the urban areas. So you find when you talk about dentists, most of the time you find that they are concentrated in just one aspect. So all the other areas, they never will have a dentist. And so when we keep talking about the number of dentists in the country, yes, there are dentists in Nigeria, but where do they work? They are located in quite a few areas, and mostly where they are trained. So, and I also want to say that the typical training in most countries is not the 4-year program that we have in the US. In Nigeria and most of the other African countries, the training is 6 years. And then you have the year 1 general studies, year 2 basic medical, and so on. And then the degrees. I mean, I was just discussing with somebody here this morning, and he was asking me, what do you mean by BCHD? We can see BCHD as one of your degrees. So you find that even the degrees are very different. The training program, very different. So we need to recognize that. And then the contribution to oral health, I have mentioned that it's more, there's a lot of maldistribution of dental personnel. So, and then within countries, it's very significant sometimes. So the oral health personnel are willing to work in rural areas due to lower remuneration, poorer standard of living, poor infrastructure, fewer colleagues, less professional support, and fewer choices and opportunities for specialization. So you then find that even where you have quite a number of dentists, you still have cases that are reported late because they don't know where to go. In Nigeria, sometimes people have to go as far as 300 and something kilometers for them to be able to meet, a dentist. Whereas we say that we have, dental schools in the country. Now, I want to go ahead and emphasize the issue of the distribution. I've mentioned that because of the time, but I want to go to the issue of problem of nomenclature. In Nigeria, we have dental surgery assistants, we have dental surgery technicians, we have dental nurses, we have dental therapists. You have all sorts of names. And so when David was conducting his study, we did exchange a couple of emails because I thought the Nigerian dental therapist would go into, what he was trying to do. But I found at the end that what we call dental therapists in Nigeria, they are actually oral hygienists. So, but because they have to be at par with the nurses and earn the same salary, they were elevated, to dental therapists so that they could earn the same salary. So there are discrepancies like that. And so when you say somebody is a dental nurse or a dental therapist or a dental surgery assistant, sometimes it depends on the context at which you are actually operating. And I want to say that in South Africa, the dental therapists there, they do, in most cases, exactly what the dentists do. So, and they can also open their own private clinics. So, but now there is a debate as to whether they should continue. There was an attempt to upgrade them to dentists, but which I don't think has been quite successful. So I just want us to have that in mind, that it changes. And so I was quite happy when Dana was talking about the primary dental health aids and the expanded primary dental health aids. And then when Laura also was talking about the situation in Nepal, where they actually train some other people to do, the job. So the issue here really is that quite a number of people conduct oral treatment in most other countries. And then among this, we have the general surgeons. They do mandibulectomies and so many things, even though they are not oral surgeons or maxillofacial surgeons. And then we have primary health care nurses, we have community health officers, we have community health extension workers, and we also have the traditional healers. So in many of these countries, so we must recognize that. And I want to emphasize here, too, that we also have the quacks. So because, as I've put it here, they are thriving because the harvest is great and the workers are very few. You can imagine before Laura started her program in Nepal, what would have been happening there. So that's why it's confusing sometimes when you have dentists coming to say, why are these people, carrying out oral treatment even after training? Whereas without them, the quacks will have the field day, they will do whatever they like. So I want us to, really take note of that. And then the traditional healers, I just want to emphasize here because that there are about 200,000 traditional healers practicing in South Africa, compared with the 25,000 doctors of modern medicine. And in most parts of Nigeria, the traditional healers still do extractions, they still do so many things, in those communities. So it can be very, very different from what we have here. And the point here is that most countries look up to the US and the UK to establish programs. So in doing that, we really need to recognize, some of these differences. So, and the challenges, training of oral health personnel must be adapted to the local situation. We must pretend as if we don't know what's going on, and then we start from basics to establish what is ideal. And then the dominance of the medical profession is also very, very important. So because they are more in number, they have the control, so you must know how to navigate your way. And then lack of modern equipment, inadequate research output, regulatory and professional issues. There are quite a number of professional issues, which in 10 minutes I cannot enumerate here. So, but I want to, the final word I want to leave here is that the oral hygiene program, the oral health program must be dispassionate enough to recognize the peculiar needs of the community, be it in Alaska or Nigeria or Kenya or South Africa or Saudi, wherever it is. We must recognize the local peculiarities, and we must also recognize that there are people that are there to fill in the void. If we don't provide, trained personnel, untrained, we take care of whatever is in the community. Thank you very much.
All right, thank you so much, Tope. All right, our last speaker is Benoit Varan. Thanks.
Thank you very much. I just want to thank you, the organizer, for inviting me. It's a real pleasure to be here today. So the objective of my talk today, this morning, is to share with you a kind of summary of the outputs of a reflection we have had with several experts in public health from Africa and also outside, chief dental officers and some partners over the last 5-6 years in the African region. So the issue was, how can we move forward? How can we strengthen the oral health agenda considering the new global health challenges? So the presentation is in 3 parts. The first one, we will see rapidly the context and from where we are coming from. The second point is what are the global health opportunities for changes? And the last one, we will see kind of mapping of winning strategies or guiding principle. In terms of key challenges and emerging issues, a lot of things have been already developed this morning, but one thing is, of course, oral disease as one of the major NCDs continue to be a serious burden and are increasing in low and middle income countries with a growing threat of multimorbidity. So we have a lack of data, but we know that this trend is definitely the reality. As Topi mentioned, of course, a big issue related to unequal distribution, shortage of oral health professionals, and lack of appropriate facilities. We have some figures that show that 90% of oral disease remain untreated in Africa. As a result, a constantly high patient demand for essential oral health care, exerting an additional burden on the healthcare system. And we know today in Africa we are in this situation of double burden, both communicable disease and non-communicable disease. We carry out a survey, questionnaires, and it seems that half of the countries in the African region only half the countries have a national oral health policy, and all the countries have problems in terms of funding with low prioritization and political support. Another challenge is related to oral health workforce and education models who are more or less relying on dentist-centered health system. So even some countries are developing some middle-level professional. The majority of new initiatives are dentist-centered health system. The surveillance system also in oral health is outdated in most of the country and rarely included into the National Health Information System. During the last decades, vertical programmings and managing characterized by isolated disease approaches rather than integrated strategy has remained the standards. And I think it's something that we have also mentioned several times this morning. So in conclusion, if you want to be a little bit optimistic, progress in addressing the burden of oral disease in an equitable and integrated manner remains slower than expected in the African region. So now, what are the global health opportunities for changes? So the question is how to move forward, what is the way out, how can we strengthen the oral health program, initiative in public health, in research in the countries, how can we mobilize funds to support new initiatives. So in my opinion, we have few but major global initiatives into which the dental public health community should be part of. We should invest time, energy, and resources. We have to foster and build new approach based on these major global initiatives that will drive a majority of programs for the coming 2 decades. So a slide about the concept of global health, and I think it's a good opportunity with Symposium. I like very much this definition of global health. I'll let you read it. In this definition, we have more or less all the ingredients needed for building new strategies and approach. We will see later some of them. Anyway, I think this definition of global health must serve as a source of inspiration for the dental public health community. To go from concept to the reality, to the real life, it is often painful. Today and for several years now, the arena of former international public health has moved into global health. A high competitive arena, a lot of diversity of actors and stakeholders, UN agencies, international NGOs, academia, research institutions, foundations. There are many, many, many actors. It's a good thing, but all of them will explain to you that they are involved, they are part of global health puzzle. It is sometimes difficult for a chief dental officer at Ministry of Health in a country to understand who is doing what, with which of them I have to work. At the end, we need to know this reality. We must adapt to this international context and be ready to work with all of them, maybe. You have, of course, all heard about the UN high-level meeting on non-communicable disease in September 2011. That was a historical breakthrough for NCDs. And also heard about this Article 19 of the political declaration concerning NCD. That was kind of one small sentence for NCD political declaration, but maybe one giant leap for oral health community. The emerging international momentum of NCD provides a real unique opportunity for better recognition of oral health. So from this oral health perspective, the political declaration recognizes 4 main facts. First, the oral disease as part of the NCD family, one of the emerging mainstream in global health over the next few decades. 2, the common preventable risk factors approach is key to addressing the problem of oral disease. 3, the primary role and responsibility of governments is to address the global burden and threat of NCDs. And 4, the commitment of the international oral health community and partners to support national efforts. Another global health opportunity, of course, for changes is also to being part of the new agenda of sustainable development. So the SDGs set out a holistic agenda to guide global development until 2030, with goal 3, focusing on good health and well-being. The SDG agenda, which includes social determinants, NCDs, and universal health coverage, is providing an anchor and entry point for better prioritization of oral health programs. It should also be a source of inspiration for dental public health community to explore how we can contribute in such achievement. The SDG emphasizes universal health coverage as one of its key targets. It's target 3.8. Universal health coverage will only be achieved by 2030 if consistent and comprehensive health system strengthening efforts take place. If we want to improve accessibility and affordability of essential dental care, oral health community should be one of the actors working on the implementation of UHC in countries. It's also a very important opportunity. In terms of mapping winning strategy and taking account what we have saw in terms of opportunity, I just as we have now a clear view about where we are coming from, about what the international and regional context in which we are moving through, what are the guiding principles, what are the strategy. I will only mention 6 of them. They have been clearly defined in the new oral health strategy endorsed by the member states at the African region last year. The first one is public health and community-based approach. National health policy for taxation regulation is an example of such strategy. The second principle is based on ownership and leadership of the chief dental officers. The chief dental officers and other experts should lead more than oral health program. The third one is related to intersectoral collaboration and action. If we want to break down silo approach, we really need to move forward and work with other sectors, including agriculture, communication, education, trade, and industry, as an example. Another winning strategy is health system strengthening for universal health coverage. Should be a main priority, as already mentioned previously. Another one is life course approach, is one also of the guiding principle. While maintaining as clear focus on prevention of disease in children, we have also, for example, to think about the growing elderly population. And I will finish with this one related to evidence-based approaches and cost-effective intervention. We have plenty of initiatives that are only based on good ideas. Innovative approach I also welcome. And for example, I'm working on ML for NCDs using mobile technology to improve, to prevent and control NCD. And I think it's a good example of promising strategy. Thank you so much. I just hear the people who want additional information, and particularly the book we released last year, Promoting Oral Health in Africa, and also the new oral health strategy for Africa. You can just click on the link and you will have the documents. Thank you so much.
We've heard a lot of different strategies and approaches and workforce models, prevention all the way through to treatment. And we've also talked a lot today about policy and the role of policy and how that kind of shapes what's possible. Thinking about the work that each one of you do, maybe you can just share some reflections about what you think a really impactful policy change might be to actually enable some of these more creative and innovative workforce models to be disseminated and used more widely.
Beth, I'll pick up on your question. I think from a policy standpoint, we have a very interesting situation globally from the standpoint of the Minamata Convention and whether that's going to be adapted and applied in different countries. Briefly, that's simplistically a ban on mercury, but the convention wording actually has a very nice research agenda as part of how that transition would be sort of could be taken advantageously to different countries then if our primary goal on reducing mercury is actually improving oral health status so that we don't need a dental material because we all have good oral health and don't need it. How is that an example or adapted, or how do you see that? Because I think the presence in the United States has been very, shall we say, ignored. But again, if we have a global treaty that has an agenda, but we're, is it helpful? What level do we take policy to get global impact?
In the UK, my experience health policy, and there's some UK colleagues looking at Jenny and Ivor, has largely been, well, it's not followed a logical linear path. You're presented with a politician or a policymaker with problem A, solution B, so that should result in a change in health policy C. It doesn't happen like that. And it usually happens just by serendipity, by a set of circumstances. A new minister coming into government wanting to make a splash, and there's usually sometimes a window of opportunity that you can capitalize on. So I don't think there is a universal one-size-fits-all answer to this. I think you just need to understand the context, particularly the political context, and if an opportunity presents itself, be ready to strike.
Great.
Okay. Let me just follow up from there. I did a study, a PhD program, comparing oral health policies in Nigeria and South Africa. In 2014, that was concluded in 2014. Apparently, Elizabeth Kalendarian, who is professor here now, I worked with her. Okay, so thank you. I worked with her in the Department of Oral Health Policy at Harvard as visiting professor for 1 year. And that fired my interest in working in that particular area. The finding is that most of these policies just exist. They're just there, and they are never followed. And the reason is because the very foundation of establishing those policies are usually faulty. You find that the people who are involved, they are not the people who will implement, and the people that are expected to implement are not interested in implementation. They are interested in the funds that will come, through that program. So let me give a quick example. In Nigeria, for example, we have an oral health policy, which is supposed to be implemented at the local government level. But during the program, the policy formulation, nobody was invited from the district government level. So at the end, we found that there was no law or regulation that we allow the local government to employ any oral health personnel in Nigeria. So, and that was a very serious problem. So I want to say that in terms of policies, yes, in Africa, we have very good policies. When you read it, you think, oh, this is the best. But they're always kept in the cooler. And I'm happy that he is here. He knows how many African countries have oral health policies. I doubt if any of those countries have been able, to implement any of those policies the way it should be.
Go ahead.
Yes, just a few words about the Minamata Convention. It's true that I didn't mention as opportunity, a global opportunity, but it's true that with UNEP, United Nations Environmental Program, and WHO, we mobilized some funds to support 3 countries in Africa, to support them to see exactly how we can manage this end of amalgam period. And it was quite interesting. It was just the phase 1, and we hope to have a second wave of support and project. But we really tried to work with this country to improve, for example, the management of waste, mercury, and also, of course, to develop some document to promote prevention and all these things. The big issue, of course, for Africa, it's the cost of the alternative of amalgam today. We organized a nice symposium during the FDI last year about this issue, and I think there are a lot of questions and few answers from the research side or industry side, or we can really move from the amalgam to something in terms of filling, and so it's also a good example, yes.
Can I add something here? There was this example in South Africa of the miners, when they were told, oh, you have to be very careful, HIV/AIDS can be devastating. And then they said the danger they face, mining is far more, involving than the problem of HIV/AIDS. So it's the same in Africa. When you talk about amalgam, and then you are talking about the danger of amalgam, there are too many things, too many problems, that even that to anybody, you really don't see it as, something that is threatening. So we must realize that people are coming from different backgrounds. Somebody who is who has suffered a lot of pain over many, maybe months, and now you have a kind of treatment that will solve that problem. He's not going to look at whether it's amalgam or anything. So I think we need to face that, and then we need to approach it in a way, that will make it enticing, for people to change from amalgam. And the real thing now is that it's becoming very expensive because, we don't manufacture amalgam in Africa, we buy it. And now it's becoming very expensive. So at the end of the day, when it's no longer available, people will then have to change. But as far as it's still available, it's going to be a bit difficult to convince people to change.
Thanks. Are there other questions? Yeah.
Dr. Pickles, was your trial conducted in an area with community water fluoridation?
No.
And what would be the prediction if it was in an area of water fluoridation? And how much was your financial incentive?
Well, firstly, Northern Ireland. The only thing that the two sides of the political and religious divide agree on is they both don't want water fluoridation. So what I didn't have time to say is that during the trial there was a huge reduction in population health caries in 5-year-olds. So there's a 22% absolute fall in prevalence in 5-year-olds. So it went to 61 to about 45, something like that. And there was probably a secular shift in reduction that's happened across the UK, but something I think quite specific had happened in Northern Ireland. And the only thing that we can attribute this to is community-based fluoride programs, so sending fluoride toothpaste out through the post. So in terms of your question about community water fluoridation, that is actually a study that we wanted to do, and we applied to our NIHR to actually do that study. We've got a very large study which is ongoing at the moment, the Catfish study, which is an evaluation of community-based water fluoridation that satisfies all of the York criteria. And we wanted to do an add-on study to run a similar thing to NICPIP in that population. But unfortunately, that grant application was unsuccessful. So I think, to answer your question, I can only speculate. I think we probably would have had a similar reduction, but we would have had a much larger, we would have had required a larger population, more expensive trial to find that reduction. So I don't know if the jury's out.
Great. There's one here in the front.
First of all, can I say thank you very much indeed to Ben and other organisers for putting on an absolutely sensational morning. Great start. Thank you very much.
Yes, absolutely.
You're not going to score for asking questions. I must have learned a great deal. What I'd like to come back to is the issue of rights-based healthcare and recognising that oral health is a basic human right. And really kind of challenging the sort of implicit paradigm that runs through a lot of this morning, which is that it's our job as dentists to solve the problem. It's pretty clear we can't and won't solve this problem acting as sole agents. I think for a long time we've put perhaps more faith in our own ability to work magic and certainly to cure the disease with the tools that we have at our disposal and fluoride. And it was Benoit Bren, really right towards the end of the morning, who reminded us that all disease is a non-communicable disease. And I'd really like to encourage us to elevate the debate somewhat, to begin to think about the challenge that we face in terms of the communities we're working with the other agencies in those communities, and particularly working with other health professionals. And here, I think we've got the challenge that Tope reminded us of very vividly, which is that it's all very well for us to say things and to issue edicts and the rest, but unless we engage with society around us, that's not going to be effective. So how do we think we can begin to have a real effect in translating all of the wonderful research that we do into action? What are the lessons that we can learn from the work that we know about, the great example of Nepal, the great example that Habib Benzin and others have had with Fit for School programs and the like? What sort of strategies, what kind of guidance would you offer us as to how we can begin to move forward so that we don't end up with 90-odd% of all disease remaining untreated?
Well, sorry, let me just, in one sentence, I want to say that what we need to do is to stop working in silos and then start to work with others. We've seen examples here. The Nepal program, they now want to invite the nutritionist, to join them. So, and then they are now having the dentist to work with them, even though they might be very critical of what they are doing, but eventually the dentist will buy into that program, the nutritionist will buy into that program, and that way you bring in quite a number of people who can be very influential. We had a program in Nigeria. The national troupe, the national dance troupe, came, to participate in that program. And they put up a show on, oral health. And the people who came to that place kept remembering, what they did. They are not dentists. They are people from drama and some other things like that. So I think the bottom line is that we must stop thinking that only dentists can do it. So we must then bring in the other professionals within dentistry and also others outside dentistry. That way we increase our own power to be able to accomplish things.
Great. Thank you so much. We are going to have to wrap it up. So I'm going to turn it back over to Ben and for the final things. Thank you so much to our panelists. Everyone.
So huge thank yous. I think 3 minutes is maybe stretching it a bit, so we'll try to go through this quickly. One more huge hand for all of our presenters and our speakers who came today. So there's a long list of people to thank. Their names are in the back of the program. I won't be able to go through all of them, but I do want to say a couple of special acknowledgments. One, we have a couple of awards to give out. They're hidden here behind this screen. We're not going to have a big ceremony unveiling, but I do want to give a round of applause. These are people who really distinguished themselves here in our School of Dentistry and did some fantastic work as students and also as mentors to students. So our Global Oral Health Mentor of the Year is Dr. George Taylor. And we've had 2 outstanding students this year, Haley Taylor and Madrima Ganguly.